Could I have your attention, please? We're going to get started in about a minute or two. The sign-up sheet is up here. If anybody is interested in signing up who has not already signed up, please come on forward now because we're going to cut it off shortly. Just so you'll know, the committee members are to sit in the front right where the pads are. Other than that, you can sit wherever you want to. Okay, folks, it's just a little bit after 1. Meeting's supposed to start at 1. Yesterday, over in LOB, Chairman Hatchett and Chairman England presented House Bill 198. And we've always said in this process there will be ample opportunity for a public hearing so that everybody who wants to be heard can be heard. Now, just so you'll remember, this is being live streamed. It is being taped. So just be careful. Don't get too excited and say something that you may regret later. So it is being taped and it is being live streamed. So, and I know this is a very emotional issue, and it will continue to be an emotional issue until this issue is resolved. We have a sign-up sheet that thus far has about 17 people in it. Because of the numbers, I'm going to limit time to 10 minutes max. At the end of 10 minutes, I will turn off the microphone. So what I plan to do is to let the people who plan to present their case. We'll start with number 1 and just work our way down the sheet. Okay, when you get up to the podium, please identify who you are and who you represent. I'm going to start it off a little bit, but you'll still have to do that once you get up there. Okay, Gina Lee, Legacy Sports.
Thank you, Chairman Smith, committee members, and the RDC members for allowing me the opportunity to represent Legacy Sports Institute and to have a voice to share our challenging journey to deliver the highest quality of care, quality outcomes, research, education, innovation, and training at a world-class facility in Alpharetta, Georgia, with best-in-class professionals, sports organizations and associations, professional athletes, global brands, and key individuals in this state to improve health care, inspire development in all our communities in Georgia. Our CON process began in 2014. We were awarded the CON twice from the experts at DCH, spent over $3 million in 4.5 years, and after opposition and many appeals, August the 27th, 2018, the state Supreme Court rejected to hear our case. This legislative session and process is our last opportunity to build a world-class surgery center focused on research, education, innovation, and training on a 30-acre comprehensive campus. Our only reason for going through this CON process was truly to be able to utilize our unique design to enhance education and training of other physicians and healthcare professionals to be able to collaborate and be involved in learning from some of the best orthopedics in the world. We have had so many support letters at the global level, and I have shared many of those with Chairman Smith and the committee. Some of those include John Smoltz, Mr. Tom Cousins, Major League Baseball Players Association, Major League Baseball Players Alumni Association, Brooks Robinson, Junior NBA, the Skill Factory, and Andy Arlotta and the Georgia Swarm. We have so many unique components to our comprehensive campus, but a few of those that are so special to us and we feel bring so much value to this state are the fact that we have a policy: we never turn away an injured high school athlete, no matter if they have insurance or the inability to pay. And we feel like the payback that we get to see these young kids succeed in sports and in life and become productive citizens in our society is far greater than any pay that we could physically receive. We do offer the standard of excellence for sports medicine across the world, and we provide the accessibility to anyone that would like to be able to receive the best outcomes in sports medicine. We have committed to this state above the 3% current that is required. We have committed to 5% indigent care. We also have a nonprofit side of our campus as a foundation that allows us to provide global research, education, military programs, youth prevention of injury programs, and something very special to Dr. Andrews is our fellowship training program. So through this money and foundation, we're able to fund 4 orthopedic surgeons a year and 2 primary care physicians that have a desire and passion to specialize in sports medicine. And what this does is help retain healthcare professionals in this specialty, especially in the rural areas of Georgia where much needed healthcare professionals to provide care to our rural communities. We also provide a program that we would like to implement here. We've done in Alabama, where we paid and funded over 130 athletic trainers to be provided through all the high schools, and especially the rural areas that may need some extra financial assistance. And in some cases, that may be the only emergency medical trained individual in those areas, and they can at least act as a liaison for the community and the athletes in those high schools to the closest rural hospital. We've also committed to this state to collaborate and involve the rural hospitals in research, education, innovation, all our different professional sports organizations that really have a passion and desire to want to give back to these kids that may otherwise not get opportunities to be involved in sports and activities that can really inspire and empower them in their life. We also have a plan to have a technology and innovation center of 125,000 square feet that will allow for collaboration with college academic institutes, medical schools, global brands, startup companies, venture capital groups, accelerator programs, and to work to innovate and provide research and commercialize products. And this campus, the first 5 years, already has an economic impact of over $1 billion for the state of Georgia. Our foundation for success has always been and will always be teamwork. It's the only way we know. We've been fortunate to be a part of helping to win many college national football championships, Super Bowls, NBA championships, and World Series. And we know from experience, to win, it takes a lot of commitment, teamwork, preparation, dedication, innovation, and a little competition. Competition can be a positive. We're just asking for an opportunity to use our own money to promote accessibility, quality outcomes, lower cost, research, education, innovation, helping to recruit other healthcare professionals to this state, and just give back to as much as we can to the citizens of this state, especially our youth. This state has one last opportunity to have the most influential individual in the sports medicine profession, and that is Dr. James Andrews. I have provided a letter to Chairman Smith as well that discusses, in Dr. Andrews' own words, his commitment to Legacy Sports Institute, to this state, and to the citizens of Georgia. And expressing our goal is to work together with the leadership in this state, other healthcare professionals and entities, people in the sports industry, and our goal is to make this state the sports and sports medicine mecca of the world. I truly believe that we all have a desire to be a part of something special, And Dr. Andrews and I both feel that this committee and the Georgia General Assembly have a unique opportunity to lead the way in making positive changes in health care. And there's an opportunity to truly set a precedent that every other state could follow. For us, it's all about working together, winning together, and most importantly, winning for the citizens of this state. So for the committee members, I ask that you think when it comes time to vote for this bill, I ask you to think about your children, your grandchildren, your niece, your nephews, the children in the communities that you serve and represent, and they all have big dreams. A lot of those kids, I can promise you, there's one young athlete that maybe their only opportunity to go to college and receive a college degree is through an athletic scholarship. Or maybe there's a young girl like me who just had big dreams to be able to train under the best doctor in the world with some of the best sports medicine professionals and to work with some of the best athletes in the world. And I can promise you they'll thank you for supporting this health care bill and giving them an opportunity to change not only their career and their lives, but the rest of their future. And so we ask that you support this bill, and we just ask you for the opportunity to build this world-class facility in Georgia and to help make this state one of the best and leaders in health care.
Thank you, ma'am. Any committee members who've come in a little late, you can come sit in one of the front two rows on the podium side, just for information. All right, second on the list, Ray Williams, Cancer Treatment Centers.
Thank you, Mr. Chairman. I think I followed Gina down in Statesboro as well, and it's not really over a good spot. She does such a great job. And I feel like preaching a little bit up here at this lectern. Mr. Chairman, thank you for the opportunity to speak on this issue, opportunity to present. And I want to thank the folks with the RDC for the opportunity to present down in Statesboro. Thank you to Chairman Hatchett, Chairman England, the other sponsors of House Bill 198. We rise today in support of that legislation. As Chairman Hatchett explained yesterday in his introduction, the bill allows for a destination cancer hospital, of which CTCA is the only one in the state, and in fact the only one that I know of in the country, to convert to a general hospital. How is this achieved? The language eliminates the 35-65 restriction. And if you're not familiar with that, the statute stipulates that we can see no more than 35% of our annual census from Georgia. And additionally, we are limited by statute to no more than 50 beds. We're also the only hospital in the state that is statutorily limited in the number of beds they can have. What do these restrictions mean? It means since probably the beginning of fiscal year 15-16, we've had to turn away or deny or delay care for 211 Georgians that wanted to seek care at CTCA. 211, right? So we need to lift those restrictions. What this does by lifting the restrictions, in essence, is it removes the need for the definition of a destination cancer hospital. It means that we would operate as a general hospital that specializes in cancer care. That's how we operate in the 4 other states in which we have hospitals. My understanding is the hospitals in other states don't have a problem with us doing this. It means that we'll continue to provide indigent and charity care and see Medicaid patients. Our Medicaid numbers have increased year over year as we see more referrals from physicians out across the state. Our indigent and charity care numbers are averaging about 4.6% over a 5-year period, which is more than the 3% average that we require to see. And while I'm on the subject of indigent charity care, let me address an issue that has been promulgated out there. The hospital industry is saying that CTCA, or Southeastern Regional Medical Center, which is how we're licensed as a general hospital, owes penalties and fines for our indigent and charity care shortfalls. I'm here to tell you today that we owe no penalties and fines. We have never been found non-compliant in our operations in the state. As you know, the Department of Community Health publishes a non-compliant list on a periodic basis. We've never been on that list, right? We've applied for 2 CONs for equipment over the last 3.5 years, and each one of those applications has been approved and the CONs have been granted. That can't happen if you're out of compliance with any regulation or rule with the Department of Community Health. So I want to put that notion to bed, that we owe penalties and fines. Unequivocally, we don't. We have followed the instructions and the directions that the Department of Community Health has provided to us and how we have operated in this state. So there are no penalties or no fines. What this bill does in this format is creates access, innovation, collaboration, specialty care for folks that need that. Cancer is not political. Cancer is personal. And if an individual wants to come to this facility, then we should create an environment where that should happen. And I'm going to close, and I probably shouldn't do this, but I'm going to. I'm going to close with a quote. And I'm paraphrasing something that the seemingly indomitable Mr. Monty Veazey said. He said, access to health care should not be determined by your zip code. Unless we change this law, if you live in Georgia and your zip code's in Georgia, your access to cancer care could be restricted. I appreciate the opportunity, appreciate the committee including us to create more access and choice in cancer care. Thank you.
Thank you, sir. All right. Georgia Hospital Association, Ethan James. Committee members, come on up front. I have 2 rows reserved for you.
Thank you, Mr. Chairman. Members of the special committee, I'm Ethan James with the Georgia Hospital Association, and I have the honor and privilege of representing nearly 170 hospitals throughout the state of Georgia, from our small rural critical access hospitals up through our large urban multi-hospital health systems. We include amongst our membership, of course, specialty facilities, including freestanding psychiatry centers, children's hospitals, and rehabilitation hospitals. And I'm here to state for the record that GHA, on behalf of our hospitals, oppose HB 198. But we do have what we consider a compromise. We have been debating this certificate of need issue for more than a decade since the last change, since 2008, when our friends down in Noonan Cancer Treatment Centers of America were able to get that special category, bypass the existing CON system, and open up for cancer care in Georgia. We left last session with what we felt was a very clear directive from both the House and the Senate to go back and consider what could we compromise on. So the Georgia Hospital Association, through a 20-member work group representing a very good cross-section of our membership from all over the state, rural hospitals, urban health systems, specialty facilities, standalone hospitals, as well as system hospitals, we formed a work group. And the work we did was to truly peel back the onion, if you will, on certificate of need, get a better understanding of exactly what our position is on this, and see where are the opportunities that we could compromise, that we could give a little bit, indeed that we could modernize that state health planning program. We asked the most difficult questions. We had the hardest conversations. We left no stone unturned in exploring the certificate of need program. And what we found is there may be opportunities to modernize that state health planning program. In fact, there used to be something called the Health Strategies Council that was responsible for keeping the CON program up to date. And it would modernize and change the formulas, the methodologies that would go into determining whether or not there was a need in a community for a certain healthcare service. It would also modernize and keep up to date the patient safety and quality requirements that goes into determining a CON. But that quit meeting in 2005 as we got into the last big CON debate under the Gold Dome. And in 2008, the General Assembly recommended that that Health Strategies Council be reformed and continue to modernize the state health planning process. Unfortunately, that never happened. It was never reappointed, and in 2012, during code cleanup, the General Assembly did away with all references to the Health Strategies Council, which means that the CON program, the methodologies and formulas that go into determining whether or not CTCA can expand their beds, if Legacy Sports can open up a orthopedic surgery center, if a multi-specialty ambulatory center can open up in an urban area or rural area, if hospitals can expand, that has not been updated in at least 14 years. And for some of these programs, it has been more than 2 decades since they've been, since those formulas have been modernized. So we do believe in that, and we are also willing to compromise on some other issues, certainly regarding the out-of-state patient percentage with regard to Cancer Treatment Centers of America. We're willing to consider changes to the capital and economic expenditure thresholds. We're willing to have conversations about the entirety of the CON system. And again, we were under what we consider a direction to go back and consider the modernization and come back and compromise. Don't come back and say no. Well, we're ready to compromise. We're ready to have those discussions. And yet HB 198 we've been hit over the head with this, not given the opportunity to compromise. And in fact, some of the changes, even in the substitute that you saw yesterday regarding how to go about bringing up a standard for how to report your indigent and charity care, that idea was just thrust upon us in committee yesterday. Well, we're the hospital association. We represent the hospitals throughout this state. Come to us, include us in this process, give us the opportunity to have a conversation about CON, because the provisions that are in HB 198 are not a compromise. They would damage the healthcare continuum throughout the state. They would do tremendous damage to our state's rural healthcare system and inflict tremendous damage to our state's rural hospitals. It would draw healthcare resources away from our rural communities and, in fact, concentrate those in the metro Atlanta area. This is not a solution to the rural healthcare problems. It would only exacerbate it. And Mr. Chairman, members of the committee, we would be looking forward to having that conversation as a compromise position on this so that we can work together as a state and all these stakeholders together in improving the healthcare access for our state. If you will, I would like to turn over to my colleague, General Counsel of GHA, Carrie Conley, to explore some of the specific concerns we have about HB 198.
Thank you, Ethan. Mr. Chairman, members of the committee. Healthcare is not a free market. It's just not. Eliminating the CON program for all but a couple of types of healthcare facilities or services doesn't make it a free market. It doesn't really even make it a freer market. It's still the only industry in our country where you have providers who are required to treat patients or consumers regardless of their ability to pay for their services. It's also the only industry where, as government contractors, we get paid less than cost. That doesn't happen to the road builders or the construction companies that are building our Army bases. It's just the healthcare industry. So getting to the specifics of the bill, I'm going to talk mostly in generalities since our time is limited, but certainly I would be happy to answer questions if anybody needs to get into more of the specifics. The bill, at the very least, does 3 things that are detrimental to hospitals. It allows freestanding imaging centers to open anywhere in the state without any type of licensure review or any kinds of quality of care standards. It would allow freestanding cardiac cath labs to open anywhere in the metro Atlanta area or anywhere else in the state as long as it's 10 miles from a hospital, without any type of verification or review of patient safety requirements. Now, right now, under the current law, if you wanted to open a cath lab that did therapeutic cardiac catheterization procedures, those are the procedures where they wind the scope up into the arteries of your heart and either put in a stent or a balloon to open up your heart so that you don't suffer from a heart attack. Currently, if a hospital were to open one of those services, they have to demonstrate that they can meet a long list of patient safety requirements, one of which is to demonstrate that an ambulance that has the capability to provide advanced life support and an intra-aortic balloon pump can be at your facility within 30 minutes in case something goes wrong during the procedure. That and none of the other quality and patient safety standards would apply to these freestanding cath labs. The bill would also allow for multi-specialty ambulatory surgery centers to open anywhere in any county in the state, regardless of the impact to the community's access to emergency services. That potential impact results because hospitals provide emergency services and other services well, trauma care, obstetrics, neonatal intensive care services, at a cost. Hospitals subsidize the cost of those services for most of their patients. So while it would be nice for everyone to have a choice of having a service provided at any number of providers, sometimes that choice ends up inhibiting the ability's community to access emergency services. And so we as a state have to decide how important that is to the communities we serve. Do we need healthcare providers to be there 24 hours a day, 7 days a week to treat the car accidents and the plant explosions? Or is it more important to have one extra choice for where you get your MRI? We heard a little bit yesterday that the bill could ultimately help bring physicians to our rural communities because it would be easier for them to open an ambulatory surgery center or have their own imaging centers in those areas. And that might be an incentive for them to move out to our rural counties. But the fact is that physicians can already open their own ambulatory surgery centers in our rural counties without a CON. And it hasn't had a significant impact on the number of physicians we have moving to those areas. The Georgia Board of Physician Workforce does a lot of research in this area, trying to figure out how we get physicians, not just to stay in Georgia, but to stay in our rural counties. They do a survey every year of the graduates of the residency programs here in the state. And one of the questions they ask of the residents that are leaving the state is, why are you leaving? 66% of the respondents to that survey that left Georgia said they did so for better location, proximity to family, better salaries, or better jobs for their spouse or partner. Nowhere on the list was their ability to operate their own imaging centers, freestanding ambulatory surgery centers, radiation therapy centers, any of that. In fact, the bill could actually make it even harder to recruit physicians to rural areas. We heard some, again yesterday, discussion about freestanding emergency rooms and what's happened in Texas when they deregulated freestanding emergency rooms. And what actually happened there was that the physicians, nurses, all types of healthcare providers in the rural areas moved away from those areas to the suburban areas that have a higher percentage of well-insured patients. Because if you're looking at it in terms of a business decision, then That's where you need to be in order to have a successful business. The hospitals that are located in our rural counties didn't locate there years and years ago because it was a good business decision. They located there because we need access to health care in rural areas. And many, if not most of them, got government grants and other government funding in order to build there. Because at that time, the federal government knew that if you didn't offer those financial incentives for hospitals to move to the rural counties, we wouldn't have access. So as Ethan mentioned, there's no arguing at this point that the CON program is perfect, that it needs to stay in place exactly as it is. As he said, the regulations haven't been updated in upwards of 20 years for some of the services. And that is actually why some of the providers that we've heard from already and will hear from, I suspect, later this afternoon, have not been able to acquire a CON. Not because the law prohibits them, but because the state health plan has not been modernized to meet the needs of our state today. So I would ask that before we throw out the entire CON program, specifically to the benefit of a few limited service providers, that we take a step back and talk about how we can improve the program and how we can give the Department of Community Health the tools it needs. One of those could be a Health Strategies Council type entity or commission to get the state health plan and the regulations modernized. And with that, I'll be happy to answer any questions, Mr. Chairman.
Okay, Chairman Hatchett.
I just have one question to Mr. James. Have I ever not greeted you and allowed you, or you been able to come talk to me about anything?
Representative Hatchett, Chairman Hatchett, you have been most gracious and always accessible, and we do look forward to working with you on a plan that can meet the needs of all Georgians. And I would just say, you know, let's please keep in mind, as we do move forward with any negotiation, when you hear terms like competition and leveling the playing field, nobody competes for the uninsured. That is the responsibility solely of the hospitals. And we do need to make sure that we secure the financial stability of our rural hospitals especially, but the entire healthcare continuum through our entire hospital system.
Looks like all the questions. Thank you, sir.
Thank you.
Looks like Emery. Oh, excuse. Okay, my mistake. Go ahead.
Thank you, Mr. Chairman.
You're on.
Thank you, Mr. Chairman, and thank you for your presentation. We have had this discussion in the Rural Economic Development Council for
Yeah.
years. And you're right. I'm not saying the current system's perfect, this and that. We gotta look at reform. Let us compromise. And I get it, I've been listening to that for years. But I gotta tell you, talking to other colleagues, I'm amazed at how I can get emails that say 100% opposed, and not say, we need to compromise, there's some things in the system that are broke, which puts us in a position to be your enemy. If you say, we don't know, well, I don't know, I've been waiting on the compromise. But for your people and your hospitals, that doesn't show compromise, that shows out a protection of turf. I would think that you give them those talking points that would say the current system isn't fair. We ask that you consider both sides, instead of we're all 100% wrong and we should oppose anything that comes before you, because you clearly agree and have said that you're not 100% right. Comments?
Yeah, Mr. Chairman, and thank you for that question, because I did actually forget to say that we have submitted to the committee chairman, Chairman Smith, a stack of letters from more than 90 of our hospitals, almost 60 of them being our rural hospitals, that do stand in opposition to HB 198 and SB 74, the companion bill over in the Senate. But
They're not against 100%.
Mr. Chairman, we stand opposed to the bill. there are elements in there that I think are outstanding. The increase for the rural hospital tax credit to $100 million, we fully support that. But the changes to the CON, which I think my comments were reflective of, is something that the Georgia Hospital Association, and clearly 90 of our members, including almost 60 of them being the rural hospitals, recognize that the changes to the CON system reflected in HB 198 are absolutely egregious. They would damage the healthcare system, and we stand opposed to that. But we do want the opportunity. We have done a tremendous amount of work as a hospital community. We want the opportunity to sit down and negotiate a better alternative to this.
Mr. Chair, and my point is, I look forward to that compromise. I truly do.
So do I.
One size does not fit all. It changes from market to market. But there's no way, some of the emails I'm getting from people that you and I both know, and you've seen a bill already, you're taking the top. That's not in the spirit of compromise. That's my opinion.
I understand that question. And we do want that, but the CON provisions, which is what we're concentrating on, of that bill, are not good for the hospital system in Georgia. Thank you.
Chairman Houston. No, I don't think you are.
I have a quick question about the map that, I don't know who put this map out.
We did.
Okay, I'd like a map showing the standalone rural hospital. When I say standalone, the ones that really are not owned by another hospital. Because are there 60 independent rural hospitals in Georgia?
It depends upon how you count that. There's approximately 60 small rural hospitals in the state, yes.
And they're independent and not owned by another hospital?
Not every single one of them, but there are certainly
could you
many,
give me-
many.
Well, I'll just look at, I know in my district, in my smaller town hospitals, they're both owned by bigger hospitals, or a part of another hospital.
And
are ruled by the other the parent hospital,
Mm-hmm.
and not by the local people.
And I would say that is due to the pressures that especially our rural hospitals are under, that they cannot survive in this financial market with the number of uninsured and underinsured patients that they see. And thank goodness
Well-
that some of our large hospitals have been able to extend that lifeline to them and keep them from closing their doors, because that hasn't happened in every community, unfortunately.
Can I make a comment on that? In my area,
Ma'am,
I
yes.
completely disagree, because Berrien Hospital was owned by some lawyers, and we were making money before we were bought. And the hospital that bought us went 2 years without a Medicaid and Medicare provider number. And in another hospital, another county I represent, was bought by a bigger hospital, and they closed the emergency room. And then we had a tornado. Now, and the people at home didn't have anything to do with that. The local people didn't. But I'd just like to see a map of the true rural hospitals. I don't know who owns what.
I will
Thank you.
I will certainly get that to you, and we would love to be transparent with the members of the committee and anybody about how the ownership
I
of
just
these
didn't
go.
think this map was very transparent of rural hospitals.
Right.
Thank
And-
you.
And I will certainly get that for you. And regarding the comment about the tornado, that is exactly the reason that our hospitals must be financially stable, so that they can stay open 24/7, 365, not 9 to 5, Monday to Friday, to handle these emergencies.
Now, you're talking about something you don't know anything about when you're talking about my emergency room being closed, because they didn't own the hospital long enough to know whether it's making money or not before they closed it.
But that's
Thank
what
you.
my emphasis is
and
on
this-
why we need that emergency
Huh.
care. My
So-
emphasis on why we need that emergency care, because when those types of incidents happen on the weekends, in the middle of the night, you don't go to a freestanding emergency room.
Well,
I mean, a
well,
freestanding
well,
ambulatory surgery
It
center.
does not go well for somebody just to come in and immediately close our emergency room. Thank you.
And thank you, Madam Chair.
One more question.
Just a quick discussion on the compromise piece. When I look at this bill, and I was not part of the group that did it from scratch by any means. A lot of great people worked on it, and they did some amazing work, I think. I think they did by going so far as to tell new entities what level of charity and indigent care they were going to have to do, so that they couldn't just cherry pick insured patients by requiring that they take part in Medicaid and Peach Care. I thought that was kind of evidence of the compromise that I would have expected. If somebody had complete repeal over here, and they had status quo like 1974 over here, I thought that where Chairman Hatchett and others ended up by requiring indigent care, charity care, find out what the statewide average, get an accurate tally on what that is, an accurate tally of how successful or profitable or not profitable by the transparency pieces, and then require them to take Medicaid. Isn't that evidence of some movement to try to take some of that burden? So if anything new opens near a rural hospital, they would have to come up and compete for charity care or else pay a tremendous 100% penalty fine. Isn't that evidence of some compromise?
Well, we'd love to sit down and discuss that more carefully, because I think there are some better ways to approach that and better ways to ensure that it is not just the hospitals on the weekends in the middle of the night that are the only ones who are responsible for taking care of those indigent charity care patients. But there are already requirements within that system for those entities to take uninsured and to do a certain amount of uninsured. And yet we stand alone in the provision of charity care being at $1.8 billion, and that is according to costs. $1.8 billion in costs that we don't get reimbursed for annually. And that's just for the hospitals just in Georgia.
You did see what the penalty is if they don't make it up to that average, that target charity and indigent care. I mean, you're familiar with the penalty?
I certainly am. I think it's 1% of net patient revenue for every half a percentage point that you miss that target.
Mind if I add something to that? The penalty also applies to our rural hospitals. And so because of the fact that it's a statewide average, by the fact that it's an average, more than at least half of our rural hospitals are going to have to pay that penalty. So we're talking about, in some cases, 5 to 10% of their net revenue, and they can't afford that. In talking about how to structure the indigent charity care requirements, because you're absolutely right, and we agree with you that they're important. One of the things that we would love to sit down and talk about is just what you said about making sure that everybody's looking at the same numbers and that we have apples to apples comparisons. The bill tries to do that with that Medicare, 1.5 times of Medicare as the basis for the indigent charity care requirement. And while that would get everybody to an apples to apples comparison, it would actually be a very big administrative burden on all of the healthcare facilities, not just the hospitals, and the Department of Community Health as well. And there are other ways to get to that apples to apples comparison that hospitals and other healthcare facilities are actually already reporting to the department. So those are exactly the kinds of things. We're certainly not opposed to providing some more transparency around those numbers. But we'd like to be able to talk about doing it in a way that streamlines the process and makes it easier for everyone, including the state.
Okay, I see no more questions.
Thank you, Mr. Chairman. Members.
Okay, thank you. Emory University Healthcare. Please identify yourself and
Good afternoon, Chairman Smith and members of the committee. Thank you for allowing me to come before you today. My name is Dr. Jonathan Lewin. I serve as the CEO of Emory Healthcare and as the Executive Vice President for Health Affairs for Emory University. I want to begin by thanking you for your efforts to look critically at this issue and for creating a forum by which we can discuss a path forward. While I come before you today to express concerns with the bill at hand, I want to make it clear that Emory hears the legislature's call for change. I come before you today to share our perspective, but more importantly, to hopefully find some areas where we can agree. I especially want to thank Madam Chair Cooper, who had a conversation with me a few weeks ago that helped me understand better the perspective of this committee and of this group, and so I'm pleased to continue that conversation today. First of all, not all not-for-profit healthcare systems are the same. Emory embraces a unique position as an academic health center, and our perspective on CON is informed by this unique role. For us, preserving some type of health planning process is critical to maintaining the broad patient volumes we need in order to do three things. First, to teach the next generation of healthcare professionals. Second, to conduct research needed to develop new treatments and new cures. And lastly, to provide the kind of tertiary and quaternary healthcare services to Georgia patients from throughout the states, many for whom we're the only provider of those services. Emory is proud to provide more than half of the residency training positions in the state of Georgia, including our training 24% of the primary care residents in Georgia, as well as a large percentage of Georgia's specialists and subspecialists. In 2018, our trainees and students reached more than 5,700 across our Woodruff Health Sciences Center programs, which also include our essential nurse education programs. We believe that as written, the bill's licensure process would unnecessarily bypass rational health planning, which would result in care fragmentation and would reduce the necessary patient mix and volumes required to operate Emory's teaching, research, and clinical programs. This is the crux of our mission at Emory. Between 60 and 70% of our net margin every year is transferred to the university's academic programs to train those healthcare professionals. Between 60 and 70% of our bottom line. We have also embraced our responsibility to improve care statewide as we invest significantly in telemedicine programs that are designed to help rural areas keep patients in their local hospitals, giving those patients access in many instances to specialists who don't practice in those rural areas. We have, for instance, we've established an EICU program, telestroke program, telenephrology programs in rural hospitals to help them provide that specialty care to these patients. And in addition, in attaining designation as Georgia's only NCI, National Cancer Institute designated comprehensive cancer center, we've committed through our Winship Cancer Institute to ensuring access for all Georgians to state-of-the-art cancer care, including access to the largest number of clinical trials in the state. The basis for our belief that the bill is misdirected is that displacement of the CON review process would eliminate the regulatory focus on analyzing the need for new facilities or services, whether they would have an adverse financial impact on existing providers, whether they can hire appropriate staff to maintain quality, and whether the proposal would have a positive relationship to the existing delivery system. The absence of health planning will result in the proliferation of unneeded and unnecessary disruptive facilities and services, and would require Emory to redirect significant resources in order to generate the patient flow to fulfill our missions. However, we do support the bill author's intent to raise indigent care thresholds to ensure this patient population is cared for, and that this responsibility is spread evenly among providers. I would offer that in order for this provision to be most effective, that threshold should be the same for for-profit as well as not-for-profit providers. We do appreciate the attention given to maintaining a balance when it comes to the opening of new healthcare facilities, particularly in the metro Atlanta area. To sustain the viability of one of Atlanta's essential healthcare systems, Emory's investing $239 million over 7 years into the former DeKalb medical facilities in order to maintain that system's commitment to providing much needed care to its communities. We support the rural hospital tax credit and support increasing or even eliminating the capital expenditure and equipment review thresholds. So I know you have a very difficult task in front of you, and I commit to you that Emory is a ready and willing partner in these discussions. If we can answer any questions or assist in any ways as you continue your deliberations, please let us know. I'd like to thank you all for your time.
Chairman Hatchett.
Thank you for your presentation. I just have one question. I'm not sure if I heard you correctly, but the indigent care requirement is for nonprofits and for-profits. Do the for-profits just get a reduction because they pay taxes? I don't know. Did you say that? I'm just making sure.
Yeah, no. So
Okay.
I was proposing that as we look at it, we look at the totality of care and we consider the same for both. I understand that you have a lower threshold. I'm just saying we would propose that you consider having the same threshold.
So you don't think there should be any credit given for an entity that pays their property taxes, their income taxes, and their sales taxes?
As I've said, I think that having a level there, so actually the short answer would be no.
Okay.
We can disagree,
We'll disagree
understand.
there.
Okay, Chairman Houston.
Do you have any idea how many federally funded health clinics we have in the state? Do you know?
I don't know the number offhand.
Well, federally funded health clinics are a big health care provider in rural Georgia.
Yes, absolutely.
And I really admire your hospital, but how many residents do you really send out to rural Georgia? I mean, are y'all participating in the residency plan in rural Georgia?
Yeah, so I, in terms of exact numbers, I can get those for you. I'd be glad to send it for you. So I think in terms of our primary care residents, again, they're going out there. I agree, the orthopedic surgeons we're training, or the head and neck specialists, probably are not any. The pediatric neurologists, probably not going there. On the flip side, when you do need a nephrologist in Swainsboro or some of the other cities, towns, our doctors are on telehealth, being able to provide those services remotely. And so getting somebody like an ear specialist, an otologist, into a small town is not going to work because there isn't enough volume for them to actually make a living, right? It's not that they may come from a small town and would love to move back. What we can do, like take nephrology, what we've done is we've had nephrologists telehealth keeping patients in small hospitals that would otherwise have to move, transfer up here to Metro Atlanta. So we're doing what we can to keep the rural hospitals going, and I understand it's a big challenge.
Well, maybe I'm focusing on primary care doctors, which we're really in need of, no more than specialists. It is really, really hard to get a primary care doctor to come to a rural area.
I agree. That's why we're trying to train a pretty good number of them.
Oh, and
About a third of our residency slots. So we have about 1,700 residents and fellows across our programs. About a third of our residents are in primary care training. So we're trying to
and they
train the workforce.
Are they doctors y'all train at Emory?
What's that?
How many doctors do y'all train at Emory to go into primary care?
Yeah, so that's a third. That's
a
at
third
Emory.
of them.
Yeah, a third of them, 34% of our
That's great.
residents.
It's good to know.
Yeah, we have a big
And I hope we can
big
get some of
commitment.
them to come down to South Georgia.
I do too. I believe.
Thank you.
I suspect we already do, but I'll try to find that number for you.
Okay. Chairman Rogers.
Thank you, and thank you for the work that you do. I would love to see those numbers as well as any of the minutes that Emory has where they've discussed internally what they're doing within their programs to encourage physicians to go to rural Georgia.
Yep, that sounds great. I will be glad. I'm not sure we have minutes, but I'd be glad to find out, just because.
Well, everybody, and again,
yeah,
this isn't an anti-Emory thing, but everybody says this is something we've always been working on, and we always ask them, show us what you've done.
Oh yeah, no, I'll be glad to show you what we've done.
And I
we'll
appreciate-
work on getting a summary to
And
you.
I appreciate the telemedicine part, but as you know, we're discussing broadband.
Mm-hmm.
And so there's always a part of me that goes, but if people can't receive health care treatment the way you would propose on and being a partner in the telemedicine, which I appreciate, then it doesn't matter if you don't have the technology. Does that make sense?
Yeah, it depends on what level. So
Yeah.
an EICU requires broadband.
Right.
The kind of telenephrology consults we're able to do, maybe not to everyone's house, but we're doing these.
Have
to
you
the
had
hospital.
discussions with those places in South Georgia or North Georgia that doesn't have the broadband on how we can help that and what a partner you can be in that regard as it relates to telemedicine?
Yeah, so again, the technological infrastructure I can't speak to. We have about 20 hospitals, most of which are in Middle and South Georgia, with whom we're working. And again, we've been able to make those teleneurology links to those hospitals. Not necessarily EICU. We have a program right now trying to bring EICU services to more rural hospitals. And that does require a broadband link that perhaps will exclude a number of those hospitals,
Right,
but we're
right.
trying.
And all I'm saying, this isn't an Emory thing, and people tell us how proactive they've been, and then I ask them, great, show me that evidence.
Yeah, I can show you. I can show you.
And they
if
hang
you
their,
like 3 years ago.
they hang their hat on things like broadband when everybody doesn't get it. And then finally, you mentioned on the point about, and I think it's a good one on the regulation of it, you mentioned about making sure that you have the personnel to be able to equip. I think that was number 2 on the point. And Chairwoman Cooper and I have talked for years about the shortage of nurses. So that wouldn't be a rule thing.
Yeah, we're actually working, our School of Nursing is working actively on improving the rural nursing workforce.
So you have
and I would be glad to, because we have a program right now that we're rolling out to try to increase that.
And I guess my point was I didn't want to make it specific that a shortage of personnel related to just rural.
No, there's shortage, yeah. We've actually more than doubled the size of our nursing class to try to help provide the state with the needed nurses, much needed nurses.
And I look forward to the information I requested. Thank you so much.
Yeah, we will get it noted. We will get that to you. Thank you. Good, thank you all for your attention.
Okay, thank you, sir. I think next on the agenda is Wellstar.
Thank you, Chairman Smith, and also members of the committee for giving us this opportunity today. I am Dr. Rob Schreiner. I'm a pulmonary and critical care physician licensed in the state for about 30 years or so. And I'm speaking on behalf of Wellstar Health System today and collectively the nonprofit hospitals in the state. So proponents of this bill assert that CON stifles competition, particularly or, for example, among ambulatory surgical centers. Yet, we in Georgia have the 4th highest number of ambulatory surgical centers in the country, and when population is accounted for, we have the highest number of ASCs per capita. Number 2, proponents assert that we need more for-profit health care in the state. Our system rescued 5 hospitals in 2016 that for a decade and a half were owned and operated by a for-profit company. And I can tell you from the inside, we had to, they were under-resourced. We had to substantially improve workflows, culture, staffing, and the physical plant, and we're still working on it. So I don't know that we need more for-profit health care in our state. My colleague from the GHA mentioned that health care is not a free market. We may want it to be, but in practice it isn't. And it's not just because of the high levels of regulation from the feds and elsewhere. And it's not just because we nonprofit systems have to take care of all patients at all hours of the day. It's also because much of healthcare is just in time. So a patient may not know yesterday that they needed healthcare today. We're there 24/7, 365, the community hospitals, to take care of all those patients. Proponents of the bill, I believe, are asserting that the pieces and parts of healthcare are more important than the whole. For example, that having special provisions for proceduralists, GI doctors, ophthalmologists, ortho, that somehow the work that they do is more noble than the work of the collective, primary care physicians, ER docs, trauma surgeons. So to create policy that favors a niche within healthcare, I don't think serves our community. rather than looking at the whole end-to-end component, which we community hospitals do care for. Proponents also assert that the Medicare waiver program that is currently under consideration and debate would replace the lost revenue to nonprofit community hospitals that would come from dismantling CON. I know much work needs to be done before we create what the final product would be in the waiver system, yet what we can glean from what's available in the public record about the waiver system, we've modeled it financially, and only 30% of our patients are covered by commercial insurance. Just a small shift in those commercially insured patients to a for-profit system or a entity that doesn't need to take all comers or all kinds of care would tank the finances of a lot of very well-run, very frugal nonprofit health systems in the state. Proponents assert that CON provides no benefit to citizens of the state, yet the margin that we're able to create in certain campuses, precisely because of CON, enables us to fund the renovation and the rejuvenation of those hospitals that are in less desirable areas of the state. For example, AMC Downtown, or Spalding, or LaGrange, or Spalding, or Sylvan Grove for that matter. So we are able to, systems like ours are able to provide high quality access care in non-traditional communities as a function of CON. I'm coming to the end here. Some proponents of this bill assert that the House of Medicine, the physician community in the state, is anti-CON or against CON. I will tell you it is split right down the center. If Medical Association of Georgia, which I've been involved in for decades now, and is near and dear to my heart, if the most recent House of Delegates meeting in October, Representative Cooper was there, if that is an indication of the beliefs of physicians across the state, it is 51-49 on this issue. And so please hear me when I say the physician community in the state is not a proponent of wholesale change in CON. So I'll conclude with our health system, Wellstar, provided $600 million of community benefit last year. We'll do more than that this year. We often think of the phrase safety net hospitals ascribed to a single entity in the metropolitan service area. We consider ourselves a safety net system. We care for as many or more Medicaid and underfunded patients in the state compared to any other system. And part of that comes from the some of the CON laws. Let's modernize, but not dismantle it completely. Thank you.
Okay, I don't see any questions. Brandon, you want to speak? Okay, very good. Thank you. Okay, Chairman Houston.
One thing in this proposal we want is transparency. By providing more transparency, will that hurt the hospitals?
Well, no. I would.
All right, so you agree with our transparency issue?
I do.
Well, good. Thank you.
May I add? No, this isn't a but. May I add, Madam, that our CEO, Candace Saunders, has consistently advocated for transparency, and we have believed we are absolutely part of participating in open records, and we have done that. And
thank you.
So
I'm glad to say that. One other quick thing. I didn't want to get into community benefits But, you know, one thing I really think we need to do is to redefine what community benefits are. Because sometimes people are getting community benefits mixed up with marketing. Thank you.
I acknowledge your point.
Thank you.
From a health system-wide standpoint, I fully acknowledge your point. We are conservative at Wellstar in how we count it.
All right. But you do know what I'm talking about.
I do, and
All right.
your point is a correct one.
Thank you.
I'm saying that we at Wellstar are very careful about that.
Good. I'm glad y'all are around. Thanks.
Okay, thank you, sir. Nafison?
Thank you, Mr. Chairman and members of the committee. My name is Julie Wyndham, and I'm Vice President of Governmental Affairs for Navicent Health System. I'm also Director of Policy and Advocacy for Stratus Healthcare. Navicent Health is a 5-hospital system with locations in Macon-Bibb, Peach, Putnam, Monroe, and Baldwin counties. And Stratus Healthcare is a collaboration of 14 hospitals all throughout Central and South Georgia. First, let me say we do support changes to the CON program. We do believe it needs to be reformed. However, we do have some concerns with this bill that I'd like to share with you. But first, I'd like to thank the sponsor for the rural hospital tax credit increase in this bill. We are fully supportive of that and look forward to working with the General Assembly to continue to improve that program. But I want to talk to you today about 2 different points as to why we have concerns about this bill. The first is the impact on rural Georgia. We believe it will have a negative impact directly on rural hospitals. 2 provisions that I want to point out to you that are changed in House Bill 98 from current law. One is currently investor-owned imaging centers, that is, those that aren't owned by physicians or hospitals, are prohibited from opening in rural areas. This bill eliminates that prohibition, and we believe that could impact our rural hospitals negatively. The second piece is that currently ambulatory surgery centers that are exempt from CON review have a 2 OR cap on the size of the facility that they can build. There are currently hospitals in this state that only have 4 ORs, particularly in rural areas, and if ASCs are allowed to build with an unlimited number of ORs, we're concerned about the impact on some of our rural hospitals. The second point on the rural impact, though, is the indirect impact that this could have on rural hospitals. I mentioned that we operate hospitals in 5 counties. We have our large flagship medical center in Macon, but we also have partnerships with 4 different rural hospitals. 2 of those we own, 2 of those are partnerships in Monroe and Putnam. We do not own those facilities. However, we have taken our time, our resources, and our expertise to work with those hospitals to try to stabilize them because we believe that care close to home is the best care. We consistently are at capacity at the medical center in Macon. We can't take any more patients, especially those that are of low acuity. We want them to stay in their rural areas. But we are worried that if this bill passes, it could have a negative impact on Navicent's bottom line and prevent us from helping our rural neighbors. For the last 2.5 years, Navicent has had a negative operating margin. Part of that is due to the fact that since 2013, our Medicare reimbursements have declined by $207 million straight off the bottom line. For 2016, which is the last year that we have audited numbers for, we did $95.5 million in uncompensated care. That is based on costs, not charges. And that was up by $15 million just from 2016. I suspect that for 2018, we will see that number continue to rise. Part of the reason for these losses is our payer mix is only 29% commercial pay. That means that less than 30% of our patients actually pay. The rest of it is government payers or uninsured care. One other point that I would like to make here, aside from the numbers and how that could impact it, is the essential services that hospitals provide that can't be provided in other care settings. In particular, the Medical Center Navicent Health is a level 1 trauma center. We are a nationally verified trauma center, and the head of our trauma program is actually the chair of the Georgia Trauma Commission, Dr. Dennis Ashley. We provide this care because we believe it is right for our community. But the Trauma Commission recently assessed what it cost hospitals to be a trauma center. For a level 1 center like Navicent, it cost me $10 million a year just to open my doors. That's before I see the first patient. And while we do get money from the Trauma Commission, and we are very thankful for the General Assembly's support of that, we only get 7 cents on the dollar of readiness costs. That means to be a level 1 trauma center, I start the year over $9.9 million in the hole just to call myself a trauma center. Then when we provide uncompensated care, we do get some money for that from the state, but that's only 17 cents on the dollar. So we are very concerned about those type of services that are uniquely provided in hospitals that cannot be provided otherwise. And we think that a strong hospital is particularly important in our area of the state. I want to mention that we work very closely with Houston Healthcare and with Robins Air Force Base to provide the specialty care that the military personnel there on the base needs, and we feel that if we are hurt, negatively impacted, that perhaps that work might be strained as well. So these are just a few of the things that we do that we feel are unique to hospitals, and we would ask you to consider the ramifications of this legislation on those unique aspects. Mr. Chairman, I'll be happy to answer any questions if you like.
I don't see any, oh, got one, Ms. Chairman Houston.
I just want to ask you the same question. What do you think about the subject of open records? Do you support open records?
I think transparency is just fine. I certainly agree with that. The only issue I would have with the way it's laid out in this legislation, and this is not for Navicent Health, this is more for the rural hospitals, is sometimes when we put regulations and reporting requirements on smaller hospitals, it's hard for them to have the staff to keep up with some of that. So we just need to consider that it not be too burdensome on hospitals. You know, I've got plenty of staff at my hospital to do that. I just
I think most people, when you find out $9.90, you can just send it right on.
Absolutely.
Thank you, because you're doing it all the way.
We certainly would support that. We just don't want duplicative reporting.
Thank you.
Yes.
Chairman Ronders.
Thank you, Julie. I really hope your answer to all these questions are no, where I can pick your brain for how do we fix this, because I'm not smart enough. Does Navicent send nurses to any schools and in those rural areas?
Send nurses to schools?
Like,
I can't answer that for you right off the bat, but I will get a note.
okay, do you take care of any of the jail populations?
Yes, absolutely.
Okay, is that uncompensated? I wish the answer was no. Is that uncompensated? Is that uninsured?
Well, it depends.
Is that community outreach?
That would not be like the school nurse or something like that. That would not be uncompensated care. That would be considered community benefit. Would be my understanding.
And I don't have a separation of those. And there's a part of me that when I see the network that some of these hospitals probably would close if they didn't have somebody helping them.
Right.
I get that.
Right.
Okay. But on the other hand, if it's those underserved areas that the jail populations aren't being taken care of.
Right, right. And I think
or the nurses aren't provided to the school, but they're provided in Bibb.
Right.
But not in, what were some of those other counties you mentioned?
Putnam, Peach, yeah.
Then to me, it's a little disingenuous to say we care about rural Georgia because you're actually cutting a deal at the central level and not at the areas that is actually more rural.
And we may
Does that make
have
sense?
those programs in those areas. I'll just have to check. I don't want to answer you right now because I don't want to give you misinformation, but I'll check.
Let me rephrase. I'm sorry, Mr. Chairman. I guess, Julie, what I'm asking is we're sitting here trying to provide access.
Right.
And part of that access, of course, is preventive care.
Correct.
We've heard that in Health and
Correct.
Human Services for a year. But those same ones that have a hub in a more urban area
Right.
aren't providing the services for preventive care to those students or the jail population.
Well, and that's
And that,
part
to
of
me,
the
there's a
reason-
part of me that goes, why wouldn't you do it in reverse? And that would be your
Right,
outreach in
right.
the more rural areas.
And we do a lot of outreach. I just can't speak to the school piece in particular. But one of the reasons why we helped found Stratus Healthcare was because we wanted to start reaching out into those areas and providing population health, basically, in those areas where the hospitals may not have the resources to do it on their own, but working with a larger partner like Navicent, they could tap into those resources.
Let me just follow up then, would you suggest that this committee look at then amending this particular bill and say your outreach or uncompensated or uninsured in some areas should be 100% towards those more rural counties than the very urban area that your home office is based? Which would guarantee that we're getting that preventive care instead of trusting it'll be done.
I think the problem with doing it that way is each community is different. Some communities may have a lot of Medicare, so there's not a lot of uncompensated care in that rural area. Whereas in Macon, I've got a lot of uninsured, uncompensated care. So it really, it's hard for the state to prescribe that for every community because each community is so different.
I would just think that the school system in Beckley County, hypothetically, would appreciate having their nurses paid for by someone based in Macon
Absolutely,
as opposed to them having to do it.
absolutely,
So,
yep.
I wanted to pick your brain on that. Thank you, Mr. Chair.
Thank you. Thank you, ma'am. All right, Northeast Georgia Healthcare System.
Good afternoon, Mr. Chairman, members of the committee. I'm Deb Bailey, and I represent the Northeast Georgia Health System. We have hospitals in Gainesville, Winder, Brazelton, and we will, within the next couple of months, open the Dahlonega Hospital that was closed last year, and we're really excited about that. We are a not-for-profit community hospital, and we have a very deep commitment to our community and providing the care that we provide. We are the third busiest emergency room in the state of Georgia with over 114,000 visits. We do have a level 2 trauma center, and as was mentioned before, and I will not repeat a lot of the things, I will not repeat the things that have been said before by the Georgia Hospital Association and by many of my colleagues, although they are very true for our system also. But we also are starting a graduate medical education program. We had to put that off for a very long time because we could not afford that. But now we've spent $8 million and we still have not taken on the first resident in that program. Our indigent care for FY18 was $220 million for our system. And many of you will say, but yes, you receive indigent care trust funds for that, and we do. Thank you very much. We received $8.8 million, which is the most we have received in years. So that leaves us with a net loss of indigent care of $211 million, and that's 19.8% of our net patient revenue. It's almost 20% of our net patient revenue for our system goes to indigent and charity care in our community. You have heard that not-for-profit hospitals do not pay taxes. Last year, FY18, we paid $863,000 in sales tax. We paid $489,000 in property tax, and in an independent audit, we demonstrated in our community for every $1 of benefit in sales tax exemption, we provided to our community over $4 for each $1. And I am happy to talk about that if you give me the opportunity and time. Our payer mix is very similar to those you've heard before. We have 51% Medicare. We have Medicaid for the system is 10%. It's almost 40% in our Winder Hospital. That leaves us with 28% of commercial, and that's all, 8% no pay. So here is what we know about what is in House Bill 198. We know that if we lose the certificate of need for multi-specialty ambulatory surgery centers, if we were to lose what we consider, and our financial people did these numbers, if we were to lose 60% of our qualifying patients for ambulatory surgery, that we would lose $38 million in Gainesville and almost $15 million in Brazelton. If we were to lose 40% of our cardiac caths, and for those of you that have not heard me speak before, you know that the Northeast Georgia Health System has been #1 in cardiac care for our outcomes for 12 years in a row in the state of Georgia and in the top 10 in the United States. We would lose over $5 million in cardiac caths, not to mention the quality. The other impact would be on our imaging, and we project that that could cost our system almost $25 million. The end of that basically is if we had 1.3 or 1.2% net patient revenue, that those losses would prevent us from doing all of the things that we do and choose to do, like neonatal intensive care, trauma, graduate medical education, and yes, we do help train nurses in our system. Like many other hospitals, what we do for our nurses is that we provide them with scholarships, and if they come to work with us, then those scholarship funds are forgiven. But that would be the impact to our system. Like those that have spoken before me, we are not in opposition to changes to Certificate of Need. We are in opposition to some of the things that are in House Bill 198, specifically as they relate to ambulatory surgery centers, cardiac caths, freestanding EDs, and imaging. So I'm happy to answer any questions that you might have. Thank you so much for your time.
Thank you. I don't see any questions.
Thank you.
Hold on one second. Excuse me.
I'm sorry, just to follow up on a kind of a question Chairman Houston had asked earlier, you have any opposition to the transparency requirements in this bill that are fairly robust?
No, we provide actually a very in-depth annual report because as a not-for-profit community hospital, we still have a governing board in our authority, and we give all of that information to our community on an annual basis.
So that part of the bill you don't have a problem with?
We do not.
How about the transparency? I noticed you mentioned the Medicare amount that your hospitals see. Would you have a problem reporting your indigent care in that Medicare allowable format that we talked about, 150% of Medicare allowable? I think you said $211 million in losses, and there's been some concern that that's based on charges. Would you have any problem with the transparency of?
We provide that information to our community, charges and costs on an annual basis for charity and indigent. And of course, that does not include the bad debt. And the bad debt that we have seen rise on an annual basis as most everyone else in them.
But as far as reporting it into the way the bill proposes, you don't have a problem with that?
We really don't. We, like was said before, we have a hard time duplicating, reporting it 27 different ways to 27 different entities. We have no problem with reporting it. Thank you very much.
Okay, the Georgia Alliance of Community Hospitals, I see you have 3 people here, and you got, I'm gonna limit that to about 15 minutes, okay? Okay, 15 for the 3, okay. Does somebody have their car going off out there? Monty, is that your car?
Yeah,
Okay.
I guess. Probably got a laser. So, Mr. Chairman, thank you. I'm Monty Veazey, President of Georgia Alliance of Community Hospitals. We represent both public and not-for-profit hospitals across the state, both rural and urban, teaching and et cetera. Today, I wanted to have 2 of our attorneys, Armando Buzzarati and Kathy Pavino, to speak to House Bill 198. Let me say at the outset, we realize that Certificate of Need may need changes brought about. And we're willing to sit down and talk to anyone about those changes and how we might come together to resolve the issue. I know the Georgia Hospital Association and the Georgia Alliance of Community Hospitals, we have a compromise bill that we have put together, and we did, as Ethan said, spend a lot of time and money on various studies in drafting that bill. I know we had like 9 meetings of our CEOs to sit down and talk about where we could give and what we could do to improve. So I'm going to turn it over to Kathy and Armando.
Monty, excuse me a second. Here, you said you have a compromise bill. Have any of the sponsors of House Bill 198 seen y'all's compromise?
No, I don't have the copy. Do you, Ethan, have it?
We have shared a broad overview for it, and I believe some members have actually seen some text of a draft.
We're waiting on legislative council to draft the bill.
Okay. Okay, let your folks go.
Good afternoon. My name is Armando Basrati. I thank you very much for the opportunity to address you and to share the Georgia Alliance's thoughts with respect to the bill at issue today. The Alliance, as I think many of you know, represents the interests of public and not-for-profit community hospitals located throughout Georgia, institutions that are vital to the delivery of acute and emergency health care services to millions of patients annually in communities large and small, urban and rural, throughout our state. And it also represents the interests and concerns of thousands of aligned medical staff physicians, independent and employed, who support the continued soundness of their community hospitals to benefit the residents of their communities and meet their health care needs. As you heard Mr. Vesey say, the Alliance is certainly in support of common sense and measured reforms to the CON program to improve it and help it better achieve its goals. However, the bill at issue is not that. It is a radical deregulation that would hurt and damage the CON program and the important protections that it provides to healthcare delivery systems and the families they serve in this state. There are consequences of this bill that we're going to briefly address in the context of our remarks today. But in essence, the general topics are this. 1, the bill would have unintended impacts that would hurt quality of care. 2, the bill would result in decreased access for Georgia families that already have the least access, those in rural areas and those who are under and uninsured, by putting the struggling hospitals that serve these groups in even more risk of going under. Also, this bill and the mechanisms it provides are likely to increase costs for health care for a number of Georgia residents, particularly those that have high deductible health plans and have to pay portions of their bills based on charges. And lastly, this bill is likely to hurt struggling rural hospitals most of all. For these reasons, which we're going to get into in a little bit more detail, we think that the bill is not something that should be pursued.
And we will be doing somewhat of a tag team approach, and I hope that that is all right with you. But we wanted to cover a lot of information in a short amount of time. So I'm not going to echo the comments that the program is broken, but what I will say is that the program, as we have it, does have safeguards. It has safeguards designed to have transparency, to have reporting of information and data. It has quality benchmarks designed to protect Georgians, and not just as patients, but as consumers, people who are required to pay for co-pays and deductibles. So there is a process, and I'll talk about it in a moment, but the new proposed licensure process is going to have unintended consequences where there's less information, and there are not the resources that are currently in place or the protections that are currently in place to protect all Georgians. I would also like to just briefly say that the system, as we've said, it needs to be updated. It is flawed. We have ideas about how it can be fixed. We'd like the opportunity to share them and work to come up with a compromise that will work for all stakeholders. And that's what the CON process used to be. Decades ago, when I first started practicing law, there was more compromise. There was stakeholder input, and you brought together the best of physicians and hospitals and others to talk through and come up with guidelines that should govern how need is measured, how accessibility is measured, and how quality is measured. So the only thing we have right now for some of these things, like quality, like what should be, for example, the number of procedures a physician, a cardiologist should be able to do before they're allowed to do a cardiac cath, an interventional cardiac cath. Those guidelines are nowhere else. So, Armando.
With respect to the Georgia healthcare system which have hospitals as its foundation, it's in financially fragile condition. I know that many of you have heard much of this before, but it takes an awful lot of capital in order to be able to meet the needs of the healthcare delivery system, particularly with the ever-rising advent of technology and advancements in medicine. These things are great, but it costs a lot of money to do that, and particularly costs a lot of money to be able to provide these things on an emergent basis and save lives. But there's no question that it's worth it. But in terms of what it costs, it's hard on hospitals and healthcare systems, and as they continue to need to invest more and more in there, the amount of revenues that they are generating is really insufficient to meet the replacement needs with respect to what they need to do. In fact, there was a study done by Cleverly and Associates, a nationally recognized healthcare industry firm, that showed that Georgia's community hospitals are about $3 billion short of what they need in order just to replace the aging infrastructure with the equipment that's going to be needed to meet the needs of their communities. Again, you've heard it before. Ms. Conley did a very nice job of describing it. It's not a free market system. Only 25% of Georgia Alliance, on average, patients are commercially insured. More than that, are Medicaid and uninsured. Together, those account for roughly 35%. So, and then Medicare comes on top of that. It's a system where there just aren't a whole lot of people that can pay, and a lot of the ones that we don't, our system hospitals always take care of, and they subsidize and have to eat the cost associated with that.
And so I would like to just briefly say, we understand that there is a proposal to substitute a new licensing process for CON, and we would caution against that, because what has happened in this bill is that parts of CON are pulled out and dropped into a licensure section. And the implications and ripple effects of this new section we would submit have not been thought through, and there may be unintended consequences, and we would ask you to consider it doesn't go far enough to protect rural hospitals and other hospitals, because the safety net hospitals are not just in rural areas, although of course that's where many of them are. But this process is essentially saying there is going to be no meaningful opportunity to determine if there is going to be a harmful impact on an existing facility. The CON laws got rid of using a 10-mile radius a long time ago because it wasn't accurate in terms of measuring distances in different areas of the state. So we're going back to things like a radius measure of what would be the impact of a new facility that the CON statute and regulations abandoned probably about 15 years ago. The standards are also vague and hard to show what would be impact. And we submit there will be a lot of litigation, and ultimately rural hospitals are going to have to spend a lot of money to try to work within this newly conceived healthcare system. We would also submit that the quality standards there's a mandate that licensure develop quality standards. We heard the same thing in 2008 when the CON Efficacy Commission unanimously recommended that licensure adopt quality standards where things were getting deregulated. So for example, in allowing facilities to do angioplasty, or what we call PCI without open heart surgery, there was the unanimous recommendation that licensure standards come in and fill the gap and have quality guidelines and benchmarks. That never happened. And the quality guidelines that are inherent in the CON process that I mentioned, stakeholders, clinicians came in together to come up with those. The state does not have the resources. They're already taxed, and one of the reasons we have issues with delays in getting Medicare certifications is that the licensure department is already strained, and the review analysts at DCH can't just be moved over because they say repeatedly they don't make those quality decisions. So the framework is not set up to have this, because licensure as it is right now, it looks at facilities. It doesn't look at services and what should be done and how it should be done across a clinical discipline. So for that reason, we would also ask you to consider that the licensure standards are not an automatic fix, and there are also exemptions that are in place now, and it's not clear how it would work going forward, because the grandfathering provisions and how they tie to existing limitations for exemptions and CONs, all of that does not work going forward.
With respect to the issue of rural hospitals, I know that a lot of folks have touched on this before, but truth be told, with respect to the exemptions that this bill provides, it would be exposing rural hospitals to cherry picking and cream skimming from a number of for-profit non-hospital providers, including many owned by national chains and private equity funds, by exempting and expanding exemptions for things like ASCs, freestanding imaging centers, and freestanding EDs. These, to the extent that rural areas have patients who can pay or are close to population centers that they might be able to serve, these are the types of facilities that this proposed legislation would encourage to come in, be built, and take revenues that might otherwise be going to these rural hospitals who desperately need them so much. At the same time, in addition to negatively impacting them with respect to the revenue side, they're going to increase costs. If these, there's already been discussion about the staffing problems, clinical staffing, nurse and other, that rural hospital providers have. To the extent that you're encouraging these other types of providers to come in close to their areas or to compete in the same labor markets they're competing, you're going to drive up the cost for those nurses and clinical staff. So at the same time you're going to hurt them on the revenue side, you're also going to increase their costs.
And Jeff, just briefly, we'd ask you to look carefully at what has happened in states that have deregulated CON, and for example, freestanding emergency departments. And what we've seen in states like Texas is that costs go up for patients. Patients who have to pay co-pays and deductibles find themselves surprised that they're getting exorbitant bills from going to freestanding EDs. We also see that in states like Maryland that did a pilot project, when you have freestanding emergency departments, you see hospitals defensively building freestanding emergency departments, which take Medicaid patients. And though the cost to Medicaid goes up, a same patient could go to an urgent care center. We see them all over the place. And the same service at an urgent care center and a freestanding ED, you're going to have a much higher cost, and that's going to hurt patients, and it's going to hurt the Medicaid system as well. And one final thing I would ask you to consider is that we have an excerpt of a report and handout to give you, but there is a ripple effect of deregulation. It costs more to get health care in states such as Texas and Arizona and Colorado that have deregulated healthcare services and no longer have CON. We're going to provide excerpts of that report, and we can provide the full report if you're interested, but it will drive up costs, not just for the individual patients, but also for the Medicaid and Medicare systems. Thank you.
Mr. Perkle.
Thank you, Mr. Chairman. The one consensus that I have found through the speakers that we've had is that a change in CON is necessary, but you don't really like what is proposed. One question that I have that I know it's a complex issue, and healthcare is a pretty weird animal, but I am an economist, and I do know that in most of the industries that I have observed over the years, where you see increased competition and decreased regulation, you see lower costs. And I've heard each of you say a couple of different times, and we had a guy from Texas and came and spoke to the Rural Development Council, and he told us the ways that they had changed their CON laws and did not suggest that, and it was not part of this process, this proposal here in this bill. But I don't understand how increasing competition and decreasing regulation is going to cost the consumer more. I can see something about the safety net and with the rural hospitals. I understand that argument, but the other one, I don't understand.
I'll start, and I'm happy to answer any other questions that you might have. But sort of one beginning point with respect to this is that, again, unlike sort of a regular free market where providers are able to serve, the patients who pay, whatever the market price is for their services, that's not what happens with respect to healthcare, at least in the context of not-for-profit hospitals who, one, have to take care of everybody who shows up in the emergency room, but two, also consistent with their mission, are taking care of everyone in the community who needs it or not. Also, with respect to the notion of healthcare, because 3/4 of the patients are not, at least in the context of our community hospitals, are not sort of commercial payers, you either have, again, folks who aren't paying at all, or you have prices that are set by monopsony payers, Medicare and Medicaid, who not only, are they monopsony payers who control enormous parts of the market, but they also put an awful lot of regulations on you with respect to what's required, like EMTALA. So those things end up having distortions, which I know you probably understand to a much greater degree than I do, on the market and how players are able to react.
Chairman Cooper.
Okay, let me see if I can summarize a couple of things. First of all, you find nothing in this bill that is of value.
We do agree that with some of the transparency provisions, and there are other changes, and not all of them, because we can talk through that.
Not all of the changes in transparency.
No, I think we agreed in concept that there needs to be more transparency, and with that, our proposal actually is more transparency across all providers. One of the things we saw, for example, in 2008, when certain facilities were deregulated or allowed, for example, surgery centers to develop more surgery centers, the state of Georgia asked surgery centers to provide data regarding
Can I stop you? Can I stop you there?
Sure.
I think this is about hospitals, and one of the things that hospitals and people that represent them tend to do is, instead of answering our questions, you start talking against the other people, and I just don't want to really hear it. So let's get back to this. So basically, other than the transparency, you don't see anything good. Secondly, I chaired the last committee on CON, and I am so glad I'm just the vice chairman this time, since I still have the scars from the last time, the way it was handled. And you're saying, and other presenters have said, that CON needs to be changed. So has your association, before this bill was presented, have you and your organization brought forth changes to CON that would maybe update it? I think you can say yes or no to that. Have you brought to any one of the legislators, to me as chairman of health, or to our leadership, have you brought a proposal for any changes?
I can only speak to the fact that there is a proposal that has been
No, I'm not
drafted.
talking about before this discussion started because a bill was put forth. Monty? No, before '08, before we passed it. That's 10 years ago. Have you? We have not. Okay. Okay. Has anybody else in the room that has said that we needed to make changes and it needed to be updated, or anybody that's going to speak, brought forth before this bill was presented, brought forth any possible changes and a proposal for changes? When, Ethan, but because I asked you, Ethan, in response to this bill coming, right?
No, actually, it was in response to the conversations we've been having for a decade. And like I said, you missed my testimony. I apologize. We have to talk further about it. But we did indeed bring a proposal after what should have been a 2-year process. We crammed it in 8 months. We did come up with a compromise proposal. We have shared that over you.
Right, I think, and I've had that over you, and that was in response, as you said before, because of my telling you that change was coming and that you best do something. You've told me that several times, as I said. Change was coming and that hospitals should come up with a viable alternative, but on your own over this period of time, before I kept pushing that, I have not had anybody bring a proposal for change. That's, just want to make that, perfectly clear. And I will acknowledge after I said that at the end of last session, you did that. Thank you. Okay.
Chairman Ronders.
Thank you, and Monty may be able to take the podium and be able to help me with some of this. And it's funny, great minds think alike sometimes, but that's kind of my point. We've been doing this rural I'm sorry, when were y'all hired?
I'm sorry?
How long have you been the attorneys? That should be an easy question.
No, me personally, earlier this year.
Earlier this year?
I'm sorry, earlier in 2018.
Okay, and you?
Likewise.
The firm has been hired for 30 years.
Yeah.
Oh, but they're new. Okay, yeah, I get it. I was just curious. But my concern was we've had bills sitting in governmental affairs for a couple of years. The Rural Economic Development Council has been meeting for a couple of years. You knew something was coming. Ethan knew something was coming. Cancer Center Treatments of America was coming. And I have yet to see your compromise. I just want to know, was there a strategic meeting held? Hold on. Was there a strategic meeting held that said, let's wait and see what they roll out? Before we show the people that have actually been engaged what we stand for instead of just being what we're against?
No, and I will not.
That's a fair question.
That's a fair question. I will not speak for the Georgia, well, I can speak some for the Georgia Hospital Association. We knew something was coming. We got the message last session, and we began immediately having put together a committee to look at everything about certificates.
But Monty, I get text that says, I'm disappointed, I don't want this, I don't want that. I don't do the privacy of that. I won't do that. And who said what? But I'm just sitting there going, why wasn't I getting that information 6 months ago of what we stand for or what we believe in or what we want to happen? Instead of just criticizing what was delivered.
Yeah, well, we would like to have more time at the Rural Development Council meeting to talk about that, but we were limited.
Ethan, you want any of this? You want any reason to tell us why you don't want to let us know 6 months ago when you knew this was coming, instead of the disappointment that some of us done to your members, not to let us know why you didn't tell us what you did like, so we could have worked on it instead of being against what's in the bill?
Let me say one thing. We started in May.
Right.
We hired consultants to look at Georgia's certificate of need. Those studies took a while to get done. We met with the Georgia Hospital Association. We got together in the fall, and
But the very members that have been friendly to you in the past.
Y'all need to use the mics, please.
That have been friendly to you in the past. It looks like on the surface that what you did is you waited until this came out and then said, we're all against this except for transparency and increasing tax, instead of putting us in the loop so maybe we could have helped with some of the things you did stand for. That's a regional strategy that you chose not to take.
Okay, so we got our compromise, but no one asked us to come to the table as you were drafting this bill. No one said, tell us what you would like or dislike in the bill. So we didn't see the bill till it was dropped.
But I'm just, okay. Maybe this is a chicken and the egg. I just wish you would have reached out.
Well,
That's a reasonable.
I always like to reach out to you.
Instead of being against everything after the fact.
Yeah.
Or giving that appearance. Now, let's, if I may, let's go down the path of, because in my world and what I know, which is limited, there's 4, 5, 6, 7 healthy revenue streams. So when people talk about those with good insurance, it's really, to me, about those revenue streams. No one has this discussion for people in the room about delivery, right? Because that's not a profitable revenue stream.
About delivery?
Yeah. It's more about imaging. It's more about ambulatory surgery centers. It's more about heart catheterizations, because they're more profitable revenue streams that those hospitals actually need. I mean, that's been your previous testimony before. Deb said that. He's shaking his head yes behind you. There's not a trick question. I'd like to know what those revenues, what those are important, because some of those are loser. Nobody wants to deliver babies in an area that's a high percentage of Medicaid because it's not cost justifiable.
Well, we have to have imaging. It's a revenue generator. Outpatient surgery is a revenue generator.
That's the ambulatory surgery center?
Yeah.
Imaging, what else?
Yeah, those are 2 big generators.
Is that it?
No, there's other, there's 100 operations within a hospital.
And that's just
And
part
I
of it.
can't tell you what
If you'd let me
all-
know that, then that's the kind of thing that we can look at. No one's trying to put the have and the have-nots in 2 different categories. So, thank you, Mr. Chairman.
Okay, that looks like all the, that looks like all the questions for right now. So we need to do the next person so we can have time to cover everybody who's got a comment to make. John Evans?
With some trepidation, I come forward. Absolutely. Good afternoon. My name is John Evans. Welcome from Macon, Georgia. I'm the CEO of the Central Georgia Heart Center. With me are Dr. Amy Kingman, managing partner of the group, and Carter Tharp, MD, interventional cardiologist. Our focus is on the cardiology part of this bill, and ultimately I'll take a step back and let them answer your questions about that as it impacts on ASCs and the authorization to allow cardiology procedures in ASCs and in other arenas. Our group is 9 cardiologists, and we serve with offices in Macon, Warner Robins, Montezuma, Hawkinsville, Forsyth, Dublin, Milledgeville. So our process is one of outreach and providing cardiology where we think is appropriate and as effective as we can, and we've done that for over 20 years. Those 9 cardiologists have a dozen nurse practitioners that help them both in the practice and in the hospital, and we employ about 100 people. So we're a relatively small player in the overall process. We do work within the Navicent Health System. We also work within the HCA hospital system. With that, I'll take a step back and yield the floor to Carter Tharp, MD.
Hi. We're doctors. We're not lobbyists or lawyers. We don't have an eloquent speech prepared, but one of the first things I wanted to explain, I'm guessing most people here aren't completely familiar with what a heart catheterization or an angioplasty is and what it entails. A heart catheterization is about a 10-minute procedure. It's done not even through an incision, it's a needle stick, either in the arm or the leg, and a little tiny latex catheter is passed up to the heart to image it. And that's how you tell if you have heart disease. And if you do, most of the time we don't have to do surgery anymore. We insert little metal stents that pass through that catheter into the artery. It's often tip to tail a 30-minute procedure or less. One that was extremely complicated might be 2 hours. When I trained, every patient that had angioplasty was admitted to the hospital. I've done about 10,000 heart caths and angioplasties, and I would say at max 15% now are even kept overnight. A heart catheterization might stay 2 or 3 hours max and go home. An angioplasty, most of them we keep for 6 hours, and if they have any problem, the vast majority of them go home the next day. And it's usually obvious within about an hour of doing the procedure whether they're going to have a problem or not. Most of the major interventional societies now, they all feel like it can be safely done as outpatient. In fact, Medicare will not reimburse angioplasty as an inpatient procedure. They recognize it as an outpatient procedure, and Medicare has recommended that angioplasty and PCI be able to be done in ASCs. I can tell you from my experience, anything in cardiology that is done as an outpatient versus an inpatient, it's vastly cheaper. I've heard some of the spiels about increasing costs. Doing things on an outpatient basis, usually whether you're talking about imaging or procedures, the reimbursement rate is much lower when it's done outpatient. It's not higher. I can't imagine how it would increase cost. It can be done cheaper. It's very rare now to have major complications with these procedures. I think for a diagnostic heart cath, I can say I've never had anybody die during one that was done on an outpatient. People having heart attacks, that's different. Those procedures are all done inpatient, obviously. But it's a very, very safe procedure. And even when you talk about stents, the major complication rate, it's extremely low. I think I might send someone emergently to surgery once every few years. I do 4 or 5 of these a day. It's been done safely without surgical backup all over this state for many, many years, and has been done in ASCs in many, many other states for years. I actually used to moonlight in an ASC when I was in training. So for us, we're more focused on the cardiology side of it. We're not experts in healthcare or policy or the bill, but we feel like this can be done safer, cheaper, with more patient satisfaction on the majority of the patients in the outpatient setting. And that doesn't pertain to everybody. I mean, a lot of these procedures we would still do at the hospital. That doesn't mean every single case, every time, would be done in an ASC. Doctors are actually pretty good at telling when they ought to do something in the hospital versus out, because ultimately, if something happens, we pay the price. I mean, we live in these communities. These people are our friends. You better believe if you do something you shouldn't be doing, it will be talked about all over town. And in my opinion, if you really want to talk about quality, it's not a series of metrics that bureaucrats generate in lists. You can go around and ask patients in a town who the good doctors are, who the best proceduralists. They all know, because they know quality when they see it. And if it's not good, they won't go there. I'm going to turn it over to Amy. She had some other points.
Hi, I'm Amy Kingman. I've learned a lot from being here today. Thanks for letting us add our 2 cents. I just wanted to speak to a few points that were brought up during this session and clarify a few things from my vantage point. As far as partnering, caring for every patient, no matter what kind of insurance they have, the doctors are there in the trenches with the hospital. You know, we're the ones at 3 in the morning coming in to take care of a patient having a heart attack when we're on city call, which means we're responsible for patients who have not established a cardiologist previously and come in with an acute cardiac condition that needs to be managed emergently. And a lot of those patients are uninsured. Some of them have Medicaid, you know. they're not all Blue Cross payers. And what a lot of times goes unrealized is that, you know, the hospitals do share the expense on the initial contact with this patient, but once a cardiac patient is always a cardiac patient. If you've had a heart attack or a stent, you're much more likely to have another procedure or another event in your lifetime. And you need to be managed closely and watched closely by a specialist to try and prevent that from happening and lower your risk, which means they come to see us either once or twice a year for us to manage their medicines, examine them, and run an EKG. And so not only do we help shoulder some of that burden of taking care of anybody, we don't ask what their insurance is, you know, we just go take care of them. But then they're our patient for life, and so we see them regularly in our office forever and ever. The other thing is licensure. I can't imagine a situation where you would have cardiologists in ambulatory surgical centers performing procedures without the appropriate licensure. You know, like Carter said, there are a handful of cases that can be done electively in an outpatient setting, but we have to be selective in who those patients are so they do well and have good results. But still, we're taking care of inpatients with more acute conditions. And, you know, we have to, in order to have privileges at the hospital, we have to pass our boards, have continuing education, perform a certain number of procedures. So we're constantly being monitored in that aspect, and also when we hire physicians to join our group, we make sure they have the appropriate credentials. Also, sometimes access to care becomes a problem. In our hospital, there are about 20 cardiologists who share the same cath lab suite, and depending on staffing at the hospital, there may be anywhere from 3 to 6 rooms available. And it can be challenging to get your patient taken care of in a timely manner when you're trying to see patients in the office and carry out other duties you may have. And so as far as, you know, efficiency for physicians, efficiency for patients, ambulatory surgical centers provide other options to access for procedures that may alleviate the burden in those situations. Thank you.
Okay. No, go ahead. Yeah, go ahead, Terry.
Okay. First of all, to the doctors, thank you very much for taking a day away from your practice to come see us. I certainly understand. My husband was a family practitioner, so I understand your commitment to patients, and I didn't bring this up to the previous presenters, but when they talked about the fact that, you know, people wouldn't be meeting the regulations or the quality, I wanted to take to say something against that also, because our physicians are not going to work in situations where they would put patients at risk. So I just want to say thank you very much for what you do. And the thing, besides convenience and patient satisfaction and the ability to do outpatient procedures, which are quicker, I think the one real major difference, and tell me if I'm wrong, from doing anything in a hospital setting when it could be done in an outpatient setting would be decreasing the possibility of a major hospital infection, no matter how careful you are. Is that correct? Because hospitals have to take care of people that come in that have MRSA and other really bad infections. They spread no matter how hard the hospitals work to contain it. And so that for patient quality and good patient outcomes, it would be better when people are not exposed to those, if at all possible. Am I right?
I'm not sure if that's ever been studied. I mean, it's logical, but whether that's true or not, I don't know.
Okay.
When doing a heart cath, when performing a heart catheterization, the access site is so small. Okay. The infection rate is very low, but when talking about utilizing single specialty ambulatory surgical centers for cardiology, you know, one of the procedures that could be performed would be implantation of pacemakers. And I don't know data, but I do know that our hospital recently has had an increased incidence of infections in those cases, so you would hope that maybe you could control that a little better.
Okay, thank you for the answer.
Representative Newton.
Thank you, Mr. Chairman. And I want to echo Chairman Cooper's point about thanking y'all for taking a day off to come at this crucial issue. And I appreciate, just like all the hospitals that are represented have a commitment to patients, it's good to see the faces of people who are out there on the other end of that small needle that you mentioned, which I'm glad it's not a large needle anymore. I don't know where I'll get my 4 bypasses, Mr. Chairman. He's been up close and personal with this. I did want to say, it does sound like you're approaching it. You mentioned your work at the hospital, your work at potentially at another location that might be able to do this. You don't see it as a battle or an either or, but more of a teamwork approach between ASCs and the hospitals. It's not that one wins and the other loses, or the...
For cardiology, you would never not do procedures at the hospital.
Right.
I mean, about probably half of what we do comes in through the hospital. Those are, people that have heart attacks. Those cases are always going to be done there. I mean, you would never send them home and then bring them back. Similarly, if you had patients that had a lot of other things wrong with them, things that in your mind are going to make them higher risk of a procedure, you're not going to necessarily do those in an outpatient setting. And like I say, doctors are pretty good at knowing that. Even if it's going to be the same procedure that takes the same amount of time, in a 50-year-old who's healthy, you can do it in an office-based setting, have them home in 3 hours, whereas someone who's 90, they're probably going to have to spend the night. I mean, even if it goes well, I mean, you're not going to keep them there.
Well, I know a couple of the main things in CON, the goals of this process too, is innovation and affordability. And it sounds like y'all are making the innovation, and I believe you said the procedure as an outpatient would be significantly cheaper for both is that insurance and the patient?
We haven't looked at the rates because we haven't explored it yet. It's always been not allowed, but virtually everything in medicine that's done in an office setting bills a lot cheaper than it is in a hospital setting. It's like, I know for imaging, it's 30 or 40%, which can translate into thousands and thousands of dollars per case.
Well, thank you very much. I mean, as an ER doctor myself who's worked at Navicent as well in the past, it's nice to know we got young doctors that are ready to take care of all of us when we need it. 24 hours a day. I appreciate you being here.
One other thing I wanted to admit, and I mean, in my mind, if you really want quality and you want to save money, do you want one place in one area doing it with no competition, no incentive to save any money, or do you want it with a bunch of people who compete to lower the cost and increase quality? And I mean, to me, it's a no-brainer.
Thank you all.
Thank you for calling us young.
Mr. Lewis? We have 6 presenters left.
Good afternoon, Mr. Chairman. Thank you for this opportunity. My name is Jimmy Lewis. I'm CEO of Hometown Health. Hometown Health is an organization that's an advise and serve organization, among many other things. And we're in the business of trying to keep rural hospitals from closing. We do everything within our power to do that, and we are in the field. Since this last session, we've done about 100 visits. I've done 100 visits into hospitals to keep up tabs on what's going on in the hospital to keep it up and going. We have 48 dues-paying members as of this morning, and there's a question about that from time to time by people in the marketplace. But to clarify the fact that we do have 48 tax-paying members, or dues-paying members, and we are involved in again the deep interventions of keeping the hospital open and going. Since about last November, we've had 30, as we can estimate, 30 hospital interventions. And an intervention goes like this. Friday afternoon at 4:30, I get a call, and the caller says, "Jimmy, we got a problem." And the problem is what? The problem is we don't have any cash. Well, what happened? Well, we didn't get a remit on Monday. We don't have any cash today. We got a $130,000 payroll that we got to make Tuesday at 2 o'clock. What do? The answer to that is I don't know, but the answer to that further is we kind of portray ourselves as the hospital fire truck with a big water hose to try to figure out how to help solve that problem. And we go to work advocating for them, with them, into all aspects of the agencies, whether it be in the mental health side of the house, and we have a lot of those, whether it be in the primary care side of the house and with the DCH, or with whatever CMOs or whatever we can deal with. So we're deeply involved in the deep inner part of keeping the hospitals open and going. We are invested heavily in doing that. We don't even have offices. We're totally virtual. I have 13 colleagues that do this, and we're in the field every day, all day. There are three parts to our organization. We do the advocacy part that we're doing right here. We do the problem-solving part. We've got 60 business partners. Interesting, CTCA is one of our business partners, and we've been asked, why in the world would you let CTCA be one of your business partners? And our answer is real simple. We're about finding the best technological advantage that we can, and we're in a major research program right now to deal with the advance of technology, and they're one of the sources. And we've got a number of sources that include DCH and Jamie Howgate, and then we've got a business partner in Quadex, and they do the same thing. So we're finding the best partners to provide and educate our people as best we can. Now, as to the subject of the bill today, I want to be very clear up front. We're an advise and serve. We go to the marketplace and we listen as much as we can. We communicate. You've got 2 communications that I provided to our members this week. And the purpose for those communications is to get feedback, and our feedback comes in a variety of forms. I get emails back on a daily basis. I get phone calls back on a daily basis, and we respond to those, and then we go to the field with those particular issues as well. One of the things I'll tell you today is on this subject, the industry, regardless of what anybody will tell you, is extremely fragmented. It's simply fragmented by the fact that, as I was coming in here, this is one of the fragmentations, and this is a letter that's out in the marketplace today about one hospital system choosing to go in a different route that it otherwise may have gone into. It was mentioned earlier that there are 160, 170 hospitals in the state. 160, 170 hospitals with 90 letters means it must be about 80 that are fragmented. This is a very difficult issue, and there is no question about it. The question is, how do we deal with it in a marketplace, and from a rural hospital standpoint, specifically, how do we deal with it? I've attempted to deal with it from this standpoint, and I've recommended to our people. The first part of the issue is we don't need to kill the bill on day one. We need to figure out what the bill says. We need to study the bill. We need to deliberate the bill. We need to go to and from to figure out what are the best parts of this bill and how does it, in fact, best apply to the rural hospital community, urban hospital community, and whoever that is. So with that in mind, we recognize that there's fragmentation. We've got to listen to everybody. And what I want to share with you today is we think that there are probably 4 different avenues in this bill that deserve some attention. And I want to share with you, as best I can, a percent airtime of what I've gotten back from the marketplace that we deal with. And I'd suggest to you that this bill, House Bill 198, may have as many as 4 different parts to it, and I'll tell you what I've heard from our people out in the marketplace. First part of the bill that it deserves attention is that called transparency. And the question is, what in the world has transparency got to do with rural hospitals and the whole issue of hospitals and how it deals, particularly in the rural aspect? And it was asked yesterday, Representative Patty Bentley, I believe, asked the question, what's the value of this whole bill to a rural hospital? Well, the value of this whole bill to a rural hospital, specifically with transparency, is to regain integrity in the data and the decisions that are made. Period, point blank, end of story. And you say, well, that's not true because everything's really good. Well, I'd suggest to you if things were really good, you look around the county or look around the state and you look at the attitudes in the county that where the county just had to assume a $38 million debt on a part of a building, that might be a problem. You look at another one that's got a $24 million debt situation on a building, that may be a problem. If you got a situation where there's a CEO that somehow or other got control of a hospital and ended up paying himself $470,000 on a 1099, that's a problem. The integrity that's lost across the state has been pervasive, and that's not to say that everybody out there is bad, but it doesn't take but 1 or 2 bad apples in a barrel to make a serious problem. And for that reason, transparency to a rural hospital system is quite important. And why is it further important? It's important from the fact that the hospital and the county commissions have to work together, and so many times we need bond referendums through the counties. If there ain't no integrity between the 2 relationships, the probability of getting money in a bond situation is terrible. And we've got about 10 or 12 bond situations right now, and one could make the case that they're easily upside down, and those counties don't like that at all. We're going to need more of that, and that's a big time issue. So trust translates into the ability to survive. These hospitals that have the counties and the hospitals themselves that need to work together, it's kind of interesting about the integrity. One of the problems is the county commissioners are elected, and for the most part, the hospital authority members are appointed. There's two different decision-making processes as it relates to being appointed versus elected. And that's necessary to have the proper trust between the parties that are involved. The second part is just one of those that's just full of angst, and it has been for 5 years, and that's CTCA. So the question is, what does CTCA and this whole bill got to do with anything? Well, we probably reach a point where we beat something totally to death. And we're probably at a point that we have beat this one totally to death. And you say, well, what does that got to do with rural hospitals? And I'd suggest to you that the amount of time that has spent trying to deal with something like the CTCA issue over the last 5 years, that time taken away from health policy that would benefit the whole system, it's crazy. I mean, it's a nightmare where we have come to in that particular point. The question is, CTCA does a lot of things wrong. I don't know if they don't do everything wrong or not, but I took on 5 issues that you brought to me, or 4 issues that you brought to me, and I said, let me figure out what the deal is. Ray alluded to one of them. I kept hearing, you know, they owe all these penalties and all these fines, so I went to peel the onion back. I didn't find that to be the case. I kept hearing about we're going to damage rural hospitals, so I went and asked, where's the specific point where CTCA has hurt a rural hospital? I didn't get any to come back. Closing hospitals. I went and looked at all the hospitals that are closed, and there are 8 of them, and I can give you the list of them. I sat in with most of the leaders of all those hospitals and cried with them as we closed them. I didn't find CTCA to be an issue, and one of them that closed. So if that's the case, then the question would be, why are we wasting energy on this issue? You know, there's an old saying, you know, where I come from, let it go. And I think we're probably at a point where it just deserves to be let go. The third issue that's in the bill is the tax credit bill. And I just got to tell you, we can talk about things that are good for rural hospitals and all sorts of stuff, but I must tell you, and I've been doing this almost 25 years, the single most beneficial action that has been taken for a rural hospital to date is the tax credit bill. And you'll say, well, why can that be? Why would you make that statement? Here's real simple. On the tax credit bill, $60 million, you take off the admin fees on the $60 million, 97% of that money goes straight into the operations of a hospital. If we take that equivalent amount of money, we put it over through DCH or somewhere, it's got to go through some kind of filtration trap where it's going to be deducted, commissioned, and all this kind of stuff. I ran the numbers, and it's in one of those documents there. The actual dollar usage comes out to be somewhere in the vicinity of about 70 to 75 cents on the dollar versus 97 cents on the dollar for what goes on with respect to the tax credit. And to go to $100 million, another $40 million would probably translate to saving 5 or 6 more hospitals. So the point in the bill that is certainly worth considering and making sure it stays in place is to advance that tax credit to $100 million. That said, the last issue is AmSurge, and that's the CON issue. This whole bill gets categorized as a CON issue. That's far more than a CON issue. The AmSurge issue, 100% of my people said they did not want to deal with CON and the AmSurge, period. They said it would kill them. My point in that would be there are 20 hospitals that would be very heavily affected because they do surgery or some form of surgery. 10 of those would be extremely vulnerable to closure. I could name them for you, but it would put them in great jeopardy. But the fourth issue, which is the AmSurge issue, 100% people that responded to me said, no, don't deal with that. So I respect and thank you for your time. I appreciate the opportunity to share with you. And for any questions, I'll be more than happy to answer those.
Well, let's see, I got one. Okay, go ahead.
Yeah, thank you. Thank you, sir. How many hospitals did you say that you represent?
48 on the dues paying, and I represent a number of other hospitals that we have contracts with. Okay. Contracts for grants and all this kind of stuff.
And would you say that if you poll those hospitals, would they say they are opposed to this bill or they would be in favor of this bill? What would the split be if you polled those hospitals?
It's just like what the doctor said earlier, 50-50, fragmented. They would start to differentiate to the issues within the bill, just like I just did for you. I gave you the differentiation from what I've heard and about the percent airtime. Transparency, you know, a little bit of labor, let it go. CTCA, well, I got 2 or 3, but let it go. Tax credit, 100% keep it. AmSurge, 100% no.
Okay, so the bottom line is you think they would be split down the middle?
Oh, yeah. This is a very divisive issue, period.
Yeah. Thank
Period.
you. Thank you, Mr. Chairman.
Thank you, Representative Nix. Thank you, sir.
Thank you.
Appreciate it. Robert Highsmith?
Thank you, Mr. Chairman and members of the committee. I'm Robert Highsmith, and I'm a lawyer with Holland and Knight, and I represent Northside Hospital. I don't represent them as a lobbyist. I represent them as lead counsel in litigation that is currently pending before the Georgia Supreme Court, likely brought by a Northside competitor. And I'm here only to talk about Section 3-5 of House Bill 198, the committee substitute thereto, and to talk about the effect that that would have on pending litigation before the Georgia Supreme Court that Northside's involved in. That's why Northside asked me to come brief the committee. Not to talk about the other transparency provisions of the bill, Madam Chairman, I'm only to talk about 3.5, which in the committee substitute. Before I do that, I want to share with the committee some news that it may have seen to the extent that it's following these things in healthcare, and that is that the merger between Northside and the Gwinnett Health System has been approved by the Federal Trade Commission. So once that transaction closes, the combined system will employ 21,000 Georgians, have an extraordinarily positive effect on the economy here in Georgia. Among the new combined systems competitors will be Piedmont, Wellstar, whom you've heard from, and Emory, who you've heard from. Northside today provides on a cost basis charity care in the amount of, this is for fiscal year 2018, $529 million, of which $315 million of that was at the Atlanta facility, $97 million of it Cherokee, and $115 million the hospital in Forsyth. It's one of the most respected healthcare delivery systems, those three full-service hospitals I just mentioned, but also with the combined system we'll have over 250 outpatient locations in 25 rural and metro counties in Georgia, including Habersham, Pickens, Greene, Baldwin, Pulaski, Bibb, Clark, Hall, Houston, and Fannin. In these metro and rural locations, Northside offers some of the best access to health care in the country. Northside doctors deliver the most babies, diagnose and treat the most new cancer cases, and diagnose and treat the most breast cancer cases in the state of Georgia. Currently holds the Joint Commission seal of approval in 10 key clinical areas, along with consistent national leadership in women's health, lung and breast cancer treatment, robotic surgery, blood and marrow transplant, heart failure, stroke care, and hip and knee replacement. So, why is Northside concerned about Section 3.5 and the litigation that it's currently in? I'll give you a brief history, Mr. Chairman, of that litigation. In 2013, a lawyer with the Atlanta firm of Jones Day, Kendrick Smith, filed a lawsuit in his own name against Northside. Northside believes that Mr. Smith's client is a competitor, a business competitor, Emory Healthcare, but that's not yet been formally disclosed. The lawsuit seeks to force the public disclosure of documents related to 4 private business transactions between Northside and several private physicians groups and other private parties. To this day, Jones Day hasn't been willing to identify their client in this lawsuit, but as I stated earlier, the suspicion is that it's Emory, but we don't know. And that's of course one of Northside's major competitors in the metro area that you heard from earlier. Northside's a private nonprofit company whose landlord for Northside Hospital Atlanta is the Hospital Authority of Fulton County, as you know. The authority decided 25 years ago that it would lease Northside Atlanta to a nonprofit private entity because in the authority's judgment, a privately operated hospital would provide better care, serve patient needs better. It's an arrangement that hospital authority, but not all hospital authorities, use to provide care. Many of you are, of course, familiar with the arrangement. Merely because of its lease with the hospital authority, Smith and his clients seek to use the Open Records Act to force disclosure of the details of those private transactions whereby Northside acquired those physician practices, something that academic hospital systems like Emory aren't required to do now or after if Section 3-5 were to become law, Mr. Chairman. So in that litigation, a 3-day bench trial was held in January of 2015. The trial court held that these private business records were not public records under the Open Records Act. The court still has yet to reach the issue of whether they may be trade secrets and therefore exempt from disclosure under those provisions of the Open Records Act. Smith appealed. The Court of Appeals agreed that the records weren't public records, but on November the 2nd of 2017, the Georgia Supreme Court announced a new test to determine whether the records were public records. Remanded it to the trial court to determine whether the records met the new test. That review hasn't yet happened because the Court of Appeals, in ruling in the case late last year, ruled that the plaintiff in the case, Attorney Smith, does not have to disclose who he's working for or which competitor of Northside's is going after the records. So that question, whether Attorney Smith has to disclose the identity of his client, is now the question pending before the Georgia Supreme Court. And the question is, can an attorney use the Open Records Act as a competitive sword against Northside Hospital while also using it as a competitive shield to shield the identity of the business competitor desiring to obtain those records of those private business transactions? And again, the ultimate question of whether the records are public or trade secrets remains to be decided by the trial court in a review that is still some months away at a minimum. Section 3.3-5 of House Bill 198 directly contradicts that Supreme Court ruling I just mentioned in two important ways. First, it defines Northside, a private entity, not the authority, but a private entity, the not-for-profit corporation, as an agency, just like any state agency. A nonprofit organization shall be an agency. The Supreme Court held the exact opposite. They said that Northside is not an agency. Its records may be subject, certain of its records may be subject to the Open Records Act, but the court held that it was not an agency. The first paragraph of Section 3-5 of the committee substitute would directly contradict that Supreme Court holding in the middle of the litigation. And secondly, it announces a definition of public record that is inconsistent with the Supreme Court's new test that it just announced in November of 2017. So, what would happen if Section 3-5 became law? First, the General Assembly has always exercised great restraint in not picking winners and losers in the middle of pending litigation. Many of the members have sat on committees that have declined to move legislation forward because the issue was before the courts and it was a time to let the courts decide. And then the General Assembly, once the ultimate decision was reached, perhaps the General Assembly might step in. This would be a break from that tradition, if I may, Mr. Chairman. But in Section 3.5, if it became law, would potentially allow a business competitor not subject to the Open Records Act, such as, for example, Emory, to access all of Northside's records regardless of what the Supreme Court has held and what the trial court may hold in this litigation. And secondly, and perhaps most importantly, it would create an unfair and unlevel playing field among private hospital systems within the world of Representative Hatchett of nonprofits. It would create an unfair and unlevel playing field because, for example, an academic system would not be subject to the Open Records Act, would not be deemed an agency under Georgia law, but merely by virtue of having a governmental landlord, as Northside Atlanta does, it would be considered an agency and all of its records subject. So what would that mean in practice? Let's say that a physician practice, there's lots of physician practice acquisitions, Madam Chairman, as you're aware. Let's say that another physician practice sought to market itself to become part of a hospital system. An academic health system might say, oh, hold on a second. We convinced the General Assembly to subject Northside to the Open Records Act. Do you really want to sign up for that and have all of your records be deemed subject to the Open Records Act? I don't think you want that. So why don't you come and join our system instead of accepting Northside's offer to become part of their system? It is an unlevel playing field that doesn't serve any of the goals that we've heard articulated here other than to create a different set of rules for for-profit systems and academic health systems and systems that have a governmental landlord like Northside with Northside's Atlanta. That's particularly galling when you consider that many academic systems receive hundreds of millions of dollars in federal and state research grants. It's not uncommon for a system like Emory to receive $300–400 million a year in taxpayer money to conduct their research. But yet Section 3-5 would not subject them to becoming an agency or subject all of their records to disclosure under the Open Records Act. Now, in conclusion, Mr. Chairman, Northside is not against transparency in healthcare. As a nonprofit, Northside's already subject to extensive transparency laws. It's already subject to the release of its tax returns, for example, which for-profit systems aren't required to do, the 990s that were mentioned earlier that become public documents once they're filed. But to serve the goal of transparency, the General Assembly need not intervene in pending litigation between competing systems, and it need not set different rules for systems like Northside that simply have a governmental landlord for one of its facilities, and other healthcare systems that don't. And that, Mr. Chairman, concludes my presentation. Happy to answer any questions that members of the committee have.
Representative Newton.
Thank you, Mr. Chairman. Just a quick question. You mentioned having a governmental landlord. Is that the same? Is that what makes it a nonprofit, and therefore does that make it exempt from federal income taxes, state income taxes, and local property taxes in a large part?
No, sir. What makes Northside as a business entity exempt from taxation is its status as a nonprofit under federal tax law. So it's just like Emory enjoys nonprofit status as a university, as all nonprofit universities do. What the connection between its nonprofit status and its governmental landlord for the Northside Atlanta campus is simply the text of what's being proposed in Section 3-5 that declares such an entity with such a lease arrangement to be an agency, and that all of its records would be subject to the Open Records Act.
Chairman Cooper.
Nice to see you.
Thank you, Madam
Finally,
Chairman.
this session. Before this bill, did this lawsuit have anything to do with CON?
No.
Okay, so it's just because of what we would possible change in the bill.
I'm only here, Madam Chairman, to talk about Section 3-5.
Okay. How long have you been the lawyer for Northside?
About 6 months.
Oh, okay.
The litigation, I succeeded Randy Evans as lead counsel in this litigation when Randy was confirmed.
Well, the reason I was going to ask, and I think Ethan has stepped out of the room. Okay. Talking about the money that the hospital spends fighting each other, I mean, this is in a different context. Do you have any idea, Ethan, how much money the hospitals have spent fighting each other, small hospitals, big hospitals, over CON approvals? Okay. I mean, I know that just in one instance when Wellstar fought for 3 or 4 years over to get the heart unit, just that one fight over CON cost Wellstar hundreds and hundreds of thousands of dollars that could have gone to patient care. And is that not sort of what happens when the hospitals fight over, another hospital getting a hospital and so forth? They run up into a lot of money. Okay, it is. Thank you.
And if I may, Madam Chairman, we don't know. We don't yet know for certain who we're fighting because of the fact that whoever this plaintiff is at present able to shield themselves with other provisions of the Open Records Act, not being required to disclose who has hired one of the largest and most prominent law firms in the country to sue Northside Hospital to have its private business records disclosed. No, I understand.
Paying out the hundreds of thousands of dollars, that's hundreds of thousands of dollars that could be going to patient care. And that's what really bothers me about the CON laws. And it's time after time after time they fight the people that want to do the surgery centers. They fight each other and run up huge lawyer bills. And that money is then diverted from patient care, which I think is really harmful. Until the CON changes that we did in 2008, you couldn't even move a parking lot across the street from your hospital without a CON, and they fought over that. So that's one of my concerns. Thank you.
Thank you, Robert.
Thank you,
I think that's all the questions.
Thank you, Mr. Chairman.
Thank you, sir. Okay, Piedmont Healthcare. Katie Childers.
Good afternoon, Mr. Chairman and members. I know the day has been long, and so I will be very brief. I'm Katie Childers, and I am the Director of Regulatory Affairs with Piedmont Healthcare as of last Monday. I picked a good time to start. First,
You drew the short straw, huh?
I did. Yes, ma'am.
Move a little closer to the microphone. Thank you.
First, we fully appreciate the tremendous amount of work that you all have put into crafting this piece of legislation. And our leadership has spent the last week analyzing it and going over it backwards and forwards. And while we do believe that most, if not all, of the goals that you set out to accomplish with this legislation can be achieved within the current CON framework, which we agree needs modernizing, we do realize that it may very well be the will of this committee and the legislature to move forward with a new system. And as that, we stand ready to work with you to create the best outcome possible. We ask that we could submit some amendment language over the next few days that we think could help greatly improve this piece of legislation, and that will create a more level playing field and protect against any unintended consequences. So thank you again, and from our entire leadership, they stand ready to offer their expertise so that we can usher in a new era of healthcare that's more competitive and more cost advantageous for the patients. That is really who we should all be here for. So thank you.
Well, very good. I see no questions. Thank you. Okay, Tony West, Americans for Prosperity.
Good afternoon, Chairman, members of the committee. I will also be brief. I want to thank you, Chairman Hatchett, as well, for introducing this legislation. My name is Tony West. I'm the Deputy State Director for Americans for Prosperity, Georgia. I'm here to testify in support of this legislation, House Bill 198. AFP and our activists engage our friends and neighbors on these key issues, one of them being health care. We want to advocate for building a patient-centered healthcare system that lowers costs, increases choices, and improves access for millions of Georgians. These reforms outlined in House Bill 198, we believe, will promote all of these important goals. As you all know, we face a severe doctor shortage in our state. I was looking up on the U.S. Department of HHS. Their estimate was over 3.2 million Georgians live in an area of the state that faces a severe shortage. Fortunately, we believe this legislation would, by eliminating most of the CON laws, would help allow more providers to serve Georgia's growing medical needs. The nonpartisan Mercatus Center has estimated that by ending Georgia's CON laws, it will allow healthcare providers to build 122 new hospitals and surgery centers, including 31 in rural communities. Expanding the availability of medical providers would significantly improve patient health. By freeing high-quality providers to serve Georgia's underserved communities, families would be receiving more life-saving treatment in a timely manner instead of waiting for their conditions to worsen. According to national hospital statistics, individuals in states without CON suffer from fewer post-surgery complications and enjoy lower mortality rates as a result of their more accessible healthcare system. This committee can ensure more families receive the healthcare they need by allowing medical providers to open new facilities and offer new services outside of Georgia's restrictive and burdensome CON barriers. We're asking you all to please vote yes on this legislation, and I respectfully encourage you to not water this down. Thank you very much.
Okay, thank you, sir. I don't see any questions. Very good. Mr. Hodges from St. Joseph's, Candler County. Oh, sorry about that. Okay.
Thank you for giving me this chance. My name is Terry Hodges, and I work for St. Joe Candler Health System in Savannah, Georgia. We are a 2-hospital system in Savannah whereby Candler is actually the oldest hospital in the oldest hospital in Georgia and the second oldest continuously running hospital in the United States of America. So that's just kind of a fun fact I always like to mention to folks. And then soon after Candler came around, we also got St. Joseph's in Savannah in 1875, started by the Sisters of Mercy. And so the reason I am here today is really on their behalf. I think I don't enjoy getting up to testify, but I know that they would really not be happy with me if I didn't stand up to mention that the mission of our organization is always kept at the forefront, and that is rooted in God's love. We treat illness and promote wellness for all people. And the promoting wellness is the piece I just want to make sure that we're not leaving out of our thought process when we're talking about CON reform. So many things that we do are outside the walls of our hospital. And I mention that for two reasons. Number one, a lot of those programs could be in jeopardy if my small 2 to 3% margin goes away. That's kind of the first things that are going to be looked at. And so we're certainly concerned about that because honestly, it's what led me to St. Joe Candler, and my favorite thing to do when I get to show people around our campus is to take them to those outreach programs out in our neighborhoods. And I would hate to see anything happen to those programs. But secondly, I just want to mention it in terms of when we're looking at what a hospital is actually doing, I don't think you can just look at the indigent care being performed in a hospital. I think we have to look. I know community benefits was mentioned. We do a community benefit report. It's a lot of times very hard to capture in terms of numbers everything we're doing. And then also we're doing things within the hospital to stop frequent flyers in our emergency room, to treat them outside in our free clinics. Now, if we just didn't do that and just took care of them in the emergency room, yeah, those indigent care numbers are going to be higher, but that's really not good policy. So I just think going forward we need to think about all of the things we're doing in the community and in terms of reporting, and also to make sure that those programs remain viable in our communities. Thank you.
Well, no questions. Thank you, ma'am. Okay, Sid Moore with the Georgia Society of Ambulatory Centers and the Georgia Society of Ophthalmology. All right. Last one.
Yeah, I'm Sid Moore from Macon, Georgia, an ophthalmologist. I've been in practice almost 30 years. I want to thank the committee for allowing us the opportunity to do this, and Chairman Smith for having us here. I do, like Representative Cooper, I do carry some battle scars from 2008. I happened to be president of the Georgia Society of Ambulatory Surgery Centers that year when we reformed some of the CON laws. I also represent still the Georgia Society of Ambulatory Surgery Centers and the Georgia Society of Ophthalmology as their legislative chairs. I'm on the MAG board of directors as well, and I've been part of the large physician-led accountable care organization here in Georgia that focuses on saving healthcare dollars. Just briefly about CON, I know it seems maybe pointless to just recap it, but CON was born in the 1970s in an era when healthcare costs were paid on a cost-plus basis. That was a way to control costs. You charge whatever you wanted to above what your costs were, you made a profit. But those days are gone. It's an antiquated law now. It's simply used as an anti-competitive tool by those that are, have it and don't want to give it up. We've heard a lot of worries and concerns this afternoon during testimony from mainly from large hospital systems about what could happen if we saw CON reformed. Probably a good way to look at this, and the Mercatus Center was mentioned two presenters ago. It's at George Mason University. I'm sure the committee's familiar with a lot of the data from that center too, but what they've done is look at what has happened when CON has been repealed in other states. There are 15 states that have repealed the law. They crosswalk it over to what could happen in Georgia if we were to repeal CON. They estimate that total health care spending in Georgia could drop by $217 per person if CON laws were repealed. They also estimate that we'd have 51 more healthcare facilities, including 38 additional rural hospitals if we didn't have CON requirements. This was mentioned earlier too, that healthcare quality measures are significantly lower in CON states. Deaths from post-surgical complications in hospitals would be reduced by 5.7% if we didn't have CON. Numbers are hard to come by. I think we do about 320,000 inpatient surgeries annually in Georgia. That translates into 19,000 fewer deaths annually in Georgia if we didn't have CON. We passed great legislation last year, the hands-free bill. That's a wonderful piece of legislation that saved 53 lives last year. Okay, so compare what this could mean. And there's no relationship between CON programs and increased access to health care for the poor. So in other words, we're not going to lose access to health care for the poor if we repeal CON. MAG has a strong policy for repeal of CON and any barriers to entry to health care here in Georgia. The American Medical Association has a strong policy on CON. Under AMA's policy, they state that CON laws have failed to achieve their intended goal of containing costs, and they may actually increase costs. CON laws are anti-competitive and a barrier to entry. CON laws are susceptible to abuse by creating opportunities for anti-competitive behavior. CON programs can impede patient choice. There's little evidence that CON laws improve healthcare quality, little evidence that CON laws improve access to care. Repealing CON laws does not lead to a surge in healthcare costs, and CON laws represent a failed public policy. The Federal Trade Commission and the new HHS Secretary favor repeal of CON. We've talked some about some of the proposals, maybe a compromise. I heard some of this that, okay, we'll take part of it, but we've got to keep CON for ASCs. Understand the different models between ASCs and hospital outpatient departments. It seems hard to really understand how this happens, but in an ambulatory surgery center, we have the same supplies, we have the same personnel, we do the same surgery, our costs are the same, yet we're paid 50% by Medicare of what hospital outpatient departments are paid for the same service. So we save Medicare 50% on those cases. ASCs save Medicare $2.3 billion each year. And if ASC's share of the market increased only 3%, within 10 years, we'd be saving $57.6 billion over that 10-year period. These are big numbers for healthcare. In Georgia, in 2015, Georgia's ASC saved Medicare $26.1 million on cataract surgery, $5.3 million on upper GI procedures, and $1.1 on cystoscopy procedures. So, if anything, what we should be trying to do is promote the growth of the ASC industry, not hinder it. And I want to thank you one more time for this opportunity. The hour's late, but we hope that House Bill 198 will survive intact.
Okay, very good. Thank you, sir. I don't see any questions. Right. Can I make a recommendation to y'all who don't agree with any kind of legislation that we may introduce? Don't send us form letters. One will do. I've got a pack here. Don't send form letters. And I'm going to do a personal privilege here, if you don't mind, Mr. Chairman. There's been a lot of discussion on sitting down and discussing this issue and compromise. Now, if we wait long enough, it'll just kind of go away. And that's not going to happen. This is just not going to go away. This is a very important issue. We're looking at the health care of the citizens of this great state. And if it involves doing a major overhaul of CON, that's what it involves. But our mission and our goal is to protect the citizens of this state. I don't know if we'll have another hearing again. We had adequate time for everybody who made a presentation today to be heard. If there's some other interest, we may hold another one, but we may have our next regular full committee meeting next week, if I can find a room. Look, that's a hard job right now with all the people having all these meetings all over the place. Any comments from any of the committee members who are left? Okay, meeting's adjourned, thank you.